am Angela Caro. I am the president of the International Society of Pharmacovigilance, ISoP. And ISoP is a society of pharmacovigilance who works in how to improve the medication safety in the world. We have presence in more than 100 countries, and we are very proud about what we are doing and the society. We have more than 14 chapters. It includes chapters of Africa, China, and North America, Latin America, and other regions. And we are organized by special interest groups too. We have some groups like We Are World Evidence, like medication errors and herbal and traditional medicines, and risk communication, and other groups. We have some meetings that are perfect excuse for meeting with some people that work in the same field that we work. For example, we have the mid-year symposium each year, and we have the biggest event in pharmacovigilance in the year in the world is the annual meeting. In the annual meeting, we have some conversations with experts who works in pharmacovigilance in different topics. We have session for each SIG, and we have the possibility to present some abstracts and oral presentations. We have events with more than 400 posters, and it is so useful for people to show his work. I think that being a member of ISoP is so important because you could build knowledge and you could share with partners about the topic that you are working in pharmacovigilance, and it helps a lot of people. It helps the patients, it helps the communities. We work with regulatory agencies, we work with WHO, we work with other people who is involved in medication safety. Then please join us, see more about us, go to our webpage, and for sure we will find something for working together.
Good morning, good afternoon, and good evening. Thank you to each of you for being here with us today to make this event possible. On behalf of the International Society of Pharmacovigilance, we are very pleased to welcome all of you to the 5th edition of the ISoP Patient Safety Day event that will be held on September 12th and 13th. My name is Hussam Salamat. I am a physician and a pharmacist. I'm based in Jordan. I am a member of the ISoP Middle East chapter and among other networks. I am delighted to host this session for the Middle East region. The World Health Organization established a dedicated Patient Safety Day to increase public engagement in healthcare safety and promote global action to prevent and reduce avoidable harm in healthcare. This year, WHO is promoting improving diagnosis for patient safety and for patient safety. ISoP reaffirms the objectives of the WHO Global Patient Safety Challenge and calls on stakeholders and health professionals to prioritize and take early action in critical areas associated with significant patient harm due to unsafe medication practices. These include high-risk situations, transitions of care, polypharmacy, lookalike, sound-alike medication, and other serious disruptions in the provision of health services. Starting, our President, Angela Caro, will address a few words to all of you. Please listen to her.
Good, good afternoon, everyone. Thank you so much for the ISoP for inviting me to present in the ISoP Patient Safety Day 2024. I would like to thank you for this great opportunity. My name is Dr. Ali Aziz Jumaili. I'm a faculty member at the University of Baghdad College of Pharmacy. I'm also a national expert at the WHO regarding the AMR. I conducted the AMR report in 2023 in collaboration with the Iraqi Minister of Health and the WHO. Today, I will talk about antimicrobial resistance in Iraq. It's really an important topic, as you know. So today, I will try to talk about the antimicrobial resistant surveillance and stewardship in general. Also, I will talk about the Iraqi situations according to the situation analysis 2023. I will brief about the literature review in Iraq. So as you know, antibiotics developed early in the 19th century with the penicillins. Then, unfortunately, after a few years of use, the antibiotic resistance developed. So as you know, in 2015, we had the last antibiotics, ceftolazone and tazobactam. And unfortunately, in 2020, we had the resistant emerge. So even the companies took many years and billions of dollars to develop one antibiotics. After a few years, this antibiotic may be not effective anymore due to the abuse and misuse of antibiotic. So when we say antimicrobial, it's any agents can kill or inhibit the growth of microorganisms such as antibiotics, antiviral, antifungals. But in general, when we talk antibiotics, we mean the antimicrobials. We mean the antibacterials. So we use antibacterials mostly in the infections to kill the bacteria. Kill the bacteria mean they are not effective against the viral. This is the major misuse in Iraq. People use antibiotics against viral infection. So what do you mean by bacterial resistance or antimicrobial resistance mean this antimicrobial is not effective anymore. So ineffective mean patient with this germs may die due to infection. Imagine we have serious infection at the hospitals and the available antibiotics are not working against those germs. So antimicrobial resistance is really global threats. According to the WHO, it's one of the top 10 global public health threats for the humanity. And there is a good chance we go back before the developing of antimicrobials. So threatening to the humanity, this serious issue. That's why we present here. We do situation analysis. We need action. We need to stop the spreading of antimicrobial resistance because we need our weapons against bacteria. If we don't have effective antibiotics, these bacteria may kill patients. So there's statistics about 5 million people death worldwide in 2019. we have multi-drug resistant bacteria, or we called also pan-resistant bacteria, which is superbugs. Pan-resistant bacteria, they are not treatable. They are resistant to any antibiotics. So if you ask me why we care about antimicrobial, we care because it's a serious issue. We care because it's an increased the length of hospitalization. It may cause treatment failure, increase significant human suffering, may lead to even death, in addition to the economic burden on the society and the Minister of Health and the families. So it's really serious issue. Human lives at risk, millions of dollars may lost. Statistics say more than 700,000 people die annually due to antimicrobial resistance, and there's expectation to become 10 million people die annually in 2050 if we don't solve this issue. So high risk, it's alarming threat. Why we have antimicrobial resistance? Because we overuse antibiotics. We have poor infection and disease control. We have poor access to good quality of antibiotics and vaccine. We have lack of awareness among general population and even some healthcare providers. And the most important things, lack of enforcement. We have the laws, but we have lack of enforcement of these laws. So what are the 5 objectives of the Global Action Plan? We need to raise awareness, strengthen surveillance and research, reduce incidence of infections, optimize use of antimicrobials, and ensure sustainable supply of antimicrobial. So imagine we don't have effective antibiotics and we don't have new antibiotics. So if we have pan-resistant bacteria, no effective antibiotics, this patient will die due to infection. So the surveillance is the first step to increase the awareness of healthcare providers and the health authorities about the current infections, the current situations. If we don't have surveillance, we don't have data, we don't have information, we don't have statistics. So it's very important to have effective AMR surveillance, which is good in Iraq. We have it in collaboration between the Ministry of Health and the World Health Organization. But unfortunately, till recently, it's limited only at the governmental healthcare settings, not the private sectors. Because in Iraq, we have private sectors and we have public sectors. Public sectors governmental run. Private sectors usually not governed by the governments. Usually, healthcare providers work independently. So the good news, if we have good surveillance, that's mean we can get good antimicrobial treatment guideline. We can inform the prescribers. Even the empirical prescriptions will be more accurate. So WHO help low and middle income countries to have good reporting systems and developed HONET, WHO net system to report the culture and sensitivity test. And we have global system of glass AMR, more than 9 countries involved in this system in collaboration with the WHO. So developed country, they are in better shape or better situation than the low-income countries, because low-income countries, they have less resources, less awareness, less enforcements, more resistance, merging of resistance. As you know, we have WHO say we have one health. The globe, we have it's a global issue. one patient from low-income country with high-resistant bacteria may travel to a country, developed country, and the resistant may transfer from one patient to another. The good things, Iraq is one of those 109 countries involved in the glass, and we have involved in both AMR and antimicrobial consumption and antimicrobial stewardship. So Iraq has already member at the WHO regarding to the glass AMR and the glass AMC, and according to the Minister of Health data and WHO data as well. So there is global action plan helped by the WHO to control emerging of resistance. So WHO try to help low-income country to enhance their surveillance, enhance their stewardship, but they cannot enforce law in their countries. So they guide us, they give us recommendations, and we need to implement these recommendations on the ground, on the healthcare settings. So first of all, we need to identify the situation as we done in 2023 in the collaboration with between the WHO and the Ministry of Health. Next step is to implement these recommendations. Okay, we know now these recommendations, we need to work. So what's the AMR surveillance in Iraq? In Iraq, we started officially with the AMR surveillance system with the WHO in 2019. We have the focal point at the Public Health Directorate at the Ministry of Health. We call it the AMR unit with Dr. Rana Abdelmehdi now. It's as a director of this unit. And she helped me to prepare the situation analysis report AMR in Iraq in 2023. So we have good surveillance system. We have report 2020, 21, 22, and I will summarize the 2022 report by the Minister of Health here in these presentations. So the good things, we have WHO net, we call it HONET system. It's all the 73 labs in 73 public hospital report their information to the headquarters of the Ministry of Health, especially the Central National Lab in Baghdad. So I would like to thank the AMR section at the Ministry of Health for providing me for these figures and statistics from the national report about the AMR in Iraq in 2022. As you can see, it started earlier in 2017, but the surveillance became more advanced with the time, especially with the help of WHO and HONET, using HONET by the public hospitals. So the lab at the public hospital use this software to report culture and sensitivity tests to the central lab in Iraq, and this information collected and the national annual report prepared by the Ministry of Health and published at the Ministry of Health website. So Iraq focal point, Directorate of Public Health, responsible for the surveillance, while the Directorate of Technical Affairs, responsible for the antimicrobial stewardship. So we have two directorates, two entities within the Ministry of Health. One is responsible for antimicrobial surveillance. Second one responsible for the antimicrobial stewardship, which is the clinical pharmacy department at the Directorate of Technical Affairs. So we have 72 surveillance sites and 72 public hospital in 11 provinces across the country using HONET software. Thank you for the WHO for training Iraqi lab staff, central lab staff about this HONET, and the staffs usually train the lab staff at the provinces. And the last training happened at the Kurdistan region in collaboration between the WHO and Iraq Ministry of Health and Kurdistan region. So HONET is really helpful, And thank you for WHO to provide it to us and to more than 130 countries worldwide, and include it could be in 44 languages, and we usually use the English version in Iraq. So this is the example of the HONAT softwares about the result of culture and sensitivity test, which is good to identify any outbreaks and collected these accumulative data. But usually they transfer data offline, not online. We still need to do online. Percent Acinetobacter has multi-drug resistant, and 67% extended day resistant, and 32% pan-drug resistant. Imagine third of Acinetobacter infections, there is no antibiotic work against them. Third of infections. So as you can see the table, high rate of resistance. So the results of the surveillance, they could give us the results. The results say we have alarming rate of resistance. What should we do? These results from the public hospitals, as well as from public hospitals. Even we have antimicrobial stewardship in public hospital, we still have high resistance because the private sector is still not under control. We have, I will explain this in the next few slides. Show alarming results. As you can see here, also the cefotaxime, ceftriaxones, we have resistant Escherichia coli, resistant to third generation cephalosporin in 75% of cases. Imagine 3/4 of cases of infections, we have resistant against third generation cephalosporin. So the news is not optimistic. High rate of resistance against third generation cephalosporin. We have only 2 antibiotic left against those bacteria. Meropenem, vancomycin, mostly antibiotic stewardship focus on the meropenem and vancomycin because the third generation cephalosporin mostly prescribed empirically by the Iraqi healthcare provider and prescribers. Empirically without culture and sensitivity test, even they are under the watch list of the WHO. As you can see in this figure, high rate of resistance, and we only left with the few antibiotic effective such as levofloxacin and vancomycin. That's why the clinical pharmacy department tried to focus on the use of those 2 antibiotics. Unfortunately, third generation cephalosporin, due to empirical prescribing, self-medications, 75% of cases resistant to those antibiotics. So we lost the third generation cephalosporin effectiveness. What should we do? We need to enforce the antibiotic stewardship, not only in the public sector, also in the private sector. In Iraq, we have a few, not more than 5 reserve antibiotics, and they are used only in severe cases, as you know. As you know, we have high rate of adverse drug reactions due to those reserve group, such as colistin, tigecycline, and linezolide. So they are only used for life-threatening cases, such as pan-drug resistant cases. So what's the current situation of antibiotic stewardship? In general, antibiotic stewardship means enhance the prescribing and enhance the use. Prescribing by healthcare provider, used by patients. So we need to improve the prescribing behavior and the use behavior. So in general, WHO classify the antibiotic into 3 categories: excess, watch, reserve. Green, excess is green. It can be used because it's narrow spectrum antibiotic, can be used safely. Watch antibiotic, it's for the more complicated cases. And the reserve antibiotic as the last choice. So it's a red color, few of them. While most antibiotic used in Iraq now under the watch list. These are some examples from the WHO, such as penicillins or the excess one. Watch antibiotic, third generation cephalosporin under the watch list, the yellow color. We have high rate of resistance to third generation cephalosporin. Colistin and linezolid under the reserve list. We have 5 of them in Iraq, 2 in the public sector, 3 in the private sector. Action plan, there is a global action plan by WHO. They are helping low-income country to control antibiotic resistance. High developed countries such as the US, they have good systems of enforcement, good system of stewardship, and they got good results. As you can see in the CDC report in 2019, they reduced the resistance of most bacteria. 40%, 21%, 3% reducing in the resistant. Good news, that means we can do it. If you follow this good example of antibiotic stewardship, enforcement, we can reach their point. Not yet. We are working toward this target, but there is slow progress in Iraq. The current situation of antibiotic stewardship in Iraq, in general, we have antibiotic stewardship at the public hospital. Clinical pharmacy program doing well in the public hospital, but unfortunately we don't have it at the private sector. Private sectors mean physician prescribe antibiotic empirically without culture sensitivity test mostly. Community pharmacies dispense antibiotics, may dispense antibiotic without prescriptions. That means patients may ask for antibiotic for their flu. They may get antibiotic without prescription, self-medications, misuse, antibiotic used for viral infection. So we really have uncontrolled situation in the private sector. We have it in the pharmacy law. Antibiotics should not dispense without prescription. Unfortunately, we don't have enforcement. We don't have electronic system. We don't have control over this stock. Still, we have dispensing of antibiotics without prescriptions. This is the reality. Clinical pharmacy doing well since 2014 at the public hospitals, but still there is not enough enforcement of the prescribers, because at the beginning there is stewardship committee including clinical pharmacist, surgeon, microbiologist. 2019 added manager of the hospitals and the infection prevention and control members and a nurse. Still, we didn't reach 100%, but still we have partial implementation of stewardship at the public hospitals. So clinical pharmacists ask physician to have culture sensitivity tests, especially for the vancomycin and meropenem and levofloxacin. So these 3 antibiotics usually under restrictions, while third generation cephalosporin usually prescribed without culture and sensitivity tests. Iraqi National Board for Drug Selections, they usually approved the new medications in Iraq We have 13 antibiotics under the excess list, 17 antibiotic under the watch list of antibiotics, and 16 anti-TB, anti-tuberculosis, and we have only 5 preserved antibiotics in Iraq. Only 5, 2 in the public sectors and 3 at the private sectors. So, high rate of infections, low reserve antibiotics. Even in animal studies, I would like to thank the Minister of Agriculture for providing us, Dr. Wael, as the IMR unit, providing us with the list of antibiotic surveillance systems in the first year of 2023. So in the law, the antibiotics cannot be used as growth promoters in the animals, but still these laws are not enforced. And as you can see, we have high rate of resistance even in animals. Those are isolated from animals in the first half of 2023. And high rate of resistance. These resistant bacteria can transfer from animal to human. So summary of literature review I conducted, I found more than 37 studies, and I will publish this soon in the WHO Mediterranean journal. In general, we have empirical prescribing of antibiotics. We have dispensing antibiotic without prescriptions. We have misuse and overuse of self-medications of antibiotic by the general populations. We have even trace or residual of antibiotic in the drinking water, and the raw beef. So antibiotics are everywhere. They are not under control. We have high resistant bacteria. Those studies give us this summary. Even some antibiotics used as a growth promoter for animals. High prevalence of resistant. So the news is not that optimistic, but we are working hard at the Ministry of Health in collaboration with WHO to control the situation at the public sectors, but still the private sector need more attention. So 37 studies, all these say we have misuse, self-medications, and awareness, low awareness level by even some of medical students and general population. Even they found resistant bacteria in the water. In conclusion of our situational report, AMR situation report in Iraq 2023, we have empirical prescribing of antibiotics at the public and private sectors. We have dispensing antibiotic at the private sectors. We have partial implementation of antibiotic stewardship at the public sectors. We have good IMR surveillance systems at the public sectors. Public sectors are is better than the private in terms of surveillance, in terms of stewardship, because there is the focus of the Ministry of Health on the public settings, while private settings still not that controlled. We have self-medications by general populations of antibiotic. Found some residual in the drinking water, in the beef, even the market in some beef. That's mean those used as growth promoters in animals. Even the bacteria isolated from animals, they have high resistance. So recommendations, we need more collaboration between Ministry of Health, Ministry of Agriculture, and other ministries to minimize the emerging of bacterial resistance, because we don't want to reach to the situation when we don't have antibiotics to treat life-threatening infections. We need to test the antibiotic residuals in the water and in the meat. We need to enforce not dispense antibiotic without prescriptions, not use antibiotic as a growth promoter for animals, We need more law enforcement, more control. I would like to thank my collaborators, Dr. Rana Abdelmehdi from the Iraqi Ministry of Health, Directorate of Public Health, IMR unit, Dr. Haider Jawadi from the Ministry of Health, Directorate of Technical Affairs, Clinical Pharmacy Department, and Dr. Abdurrahman from WHO Iraq office, Dr. Amir Baban, also WHO Iraq office, and Dr. Wael from the Iraqi Ministry of Agriculture, IMR units. They helped me to summarize the situation analysis of Iraqi IMR. Thank you. Also, I'm ready to receive any questions. Again, thank you for the ISoP for inviting me. This is my email. Thank you again. I'm ready to answer any question. Thank you very much. And hope I summarized everything about the IMR in Iraq for you. Have a good day.
Thank you so much, Dr. Ali, for this interesting presentation. And please accept my apologies for not introducing you to at the beginning of the presentation. If you may allow me to present you just another time, Dr. Ali Aziz Al-Jamali is an associate professor at University of Baghdad College of Pharmacy in Iraq, and is a consultant at Medicine Needs Estimation Division to conduct pharmacoeconomic studies in the Ministry of Health. He's the advisor of the chairman of the Iraqi Pharmacist Syndicate for Clinical Pharmacy Affairs. He's a visiting professor at the University of California Davis School of Medicine, Department of Public Health in California, USA. And he's an adjunct assistant professor at the University of Iowa College of Pharmacy in the US. He has published more than 71 peer-reviewed manuscripts in several American and European journals in different areas, including pharmacy practice, clinical pharmacy, pharmaceutical education, medication safety, in different healthcare settings, interprofessional collaboration, health literacy, pharmaceutical regulations in public health, and other social and clinical pharmacy topics. His studies were cited more than 1,000 times so far. Welcome again, Dr. Ali, and thank you for this nice presentation. And I would like to encourage the audience to use the chat and direct their questions for us to know more about the pharmacovigilance system in Iraq. I have one question so far, which got my attention, Dr. Ali. What steps should we prioritize in Iraq to reduce the AMR burden from your experience? What would you say that you mentioned that enforcement of the current regulations would help in minimize the burden of the AMR in Iraq. How would we do that? How would we collaborate with other entities inside and outside Iraq to make progress toward more enforcement and implementation of AMR regulations?
Thank you so much, Dr. Hussam, for this nice introduction. Thank you, Dr. Manan, for inviting me. Thank you for all ISoP colleagues. Actually, the IMR, as I mentioned, we have two sectors in Iraq, public and private. We have good steps at the public because we have good collaboration between the Ministry of Health and WHO. So WHO usually train the local lab workers, train pharmacists. We have received good training at the public sector. I need to pay the audience attention about the private sectors. As a pharmacist, I'm sure we have many pharmacies, they dispense antibiotics without prescription. This will lead to inappropriate use, self-medications, and emerging of antimicrobial resistance. So we need to have training to the pharmacists. We need to raise awareness. And thank you for Dr. Manal and also for you. And I hope I can receive this recording so I can spread the awareness. We need also to have enforcement by control the stock of antibiotic in each pharmacy. And this will not happen unless we have electronic system in our stock. I think now, as you know, people, they may get their bacteria resistant at the community pharmacy. So I studied my PhD at in the United States. In the United States, they don't dispense antibiotics without prescriptions. So they have control over dispensing. Unfortunately, in Iraq, we don't have this control. So I think we need to raise awareness. We need workshops. We need collaboration, our colleagues. We need also enforcement, because if we control the public sector, patient can get antibiotic at the private sectors. Also, we need to control the use of antibiotics in animal, because when I conducted the situation analysis 2023 in collaboration between Ministry of Health and the WHO, we had a group from different ministries, and my colleagues from the Ministry of Agriculture, they said some farmers or those with they raise animals, they use these antibiotics with the food of animal. So imagine the chicken size now, it's just growing from 1 kilo to 2 kilos within 3 weeks. So we usually eat local chicken. This is a good source of antibiotics. So I think as I mentioned above, we have more than one source. So WHO titled mission is we have one health. One health, that means we need to control the environment, we need to control the use in animals, you need to control the use of in human. Imagine we don't have enough resources to test antibiotic in water. So the colleagues from the environment ministry say, we don't have enough machine and resources to test antibiotic residual in water. So we may have antibiotic residual because, you know, the waste of hospital, the waste of pharmacies, I assure you, we don't have waste management, good waste management in pharmacy. So those wasted antibiotic, they may be disposed at the rivers. We drink from the river, we drink antibiotic residuals, animal source. So One Health, it's a good concept, but we need to raise awareness. The good things, because I'm the faculty member at the University of Baghdad College of Pharmacy, this year, we received recommendation from the WHO to teach antimicrobial resistance as a topic in our pharmacy program. And the good news, we have good collaboration at the college level with the WHO and Ministry of Health. So I teach public health for the 4th year. Now we have a new topic. The good news, we have no new topic. It's the first year will be introduced is AMR. So imagine pharmacy school, this will be first or second year, we will introduce the AMR, antimicrobial resistant topic. So we need all the colleges. This is at the University of Baghdad College of Pharmacy, because we are the first college of pharmacy in Iraq. But what about other colleges? So my message to my colleague at the other college of pharmacy in Iraq, other college of medicine, we need to teach our students, our prospective healthcare providers, pharmacists, we need to teach them AMR, because they are the first healthcare providers, they are most accessible. Those who dispense the antibiotic, if they are aware, we can have some control. So we need collaboration, raising awareness, and increase teaching, and we need to introduce the topic. We need collaboration. We need enforcement. Thank you, Dr. Hassan.
Thank you, Doctor. So you mentioned that more capacity building focused programs would be better equipped for Iraqi pharmacists or for Iraqi clinicians in general, for all the healthcare sector. Would there be any priorities for rolling out these capacity building programs from your point of view? Would you like to focus on pharmacists? Would you like to focus on physicians, prescribers, or the public?
I think public, we have in public, we have a stewardship program at the clinical pharmacy department. We have stewardship AMR unit at the public health directorate. They are working. They are working. They are doing their best. We still didn't reach 100. We didn't. I cannot talk in behalf of them because I'm not a MOH employee, but they are doing their best. I'm a pharmacist. I'm working as a community pharmacist in Iraq. I know we have really shortage we have gap in the controlling antibiotic dispensing in community pharmacy. So I think dispensing antibiotics at community pharmacy, it's one way. The second way at private clinics. Private clinics usually also physician prescribe antibiotic without culture sensitivity test. They may prescribe 12, 14 antibiotics. But at least they have the right to prescribe it, but without test. Imagine, without test. I think I need to mix your questions with Andrea question. Andrea talked about prescribing to levofloxacin and meropenem. We have policy in the public sector in Iraq about dispensing specific antibiotics such as levofloxacin and meropenem. So clinical pharmacy department focus on those two because those are I can say those, the excess watch reserve. Those belong to the watch, but I can say those are the last reserves we have. So if we lose them, because we lost the third generation cephalosporin, then now bacteria become resistant. 70% of bacteria, 75% of bacteria resistant to cephalosporin, to ceftriaxone. So unfortunately, because the misuse of third generation cephalosporin, especially at the private sector during COVID-19. I remember during COVID-19, everyone was taking ceftriaxone, everyone. So now, azithromycin as well. Now we have 75% of bacteria resistant to them. So the clinical pharmacy department say we need to focus on meropenem and levofloxacin. We don't need to lose those two precious antibiotics. So the good things in public sectors, they have regulations. They can ask the physician to get culture sensitivity test. So as you know, they prescribe the first doses as empirical, but they have to take the test. And when the test get the results change, they change the guideline, the therapy regimen. So the pharmacists at public sector, they have the authority to stop the doctor or to ask the doctor or to guide or to collaborate with doctors. In community pharmacy, unfortunately, we don't have enough collaboration between pharmacists and physician. So pharmacists cannot ask the physician, cannot advise them unless they have very good relation. But in general, the situation, your question is really important. If we need to prioritize our efforts, let's focus on the private sector. Public sectors doing this since 2014, 17, 19. Private sectors, we really need the WHO and other international collaboration.
In terms of the implementation of the AWARE protocol, the Watch, AWARE, Access, and Reserve, are there any initiatives in Iraq that they are compiling data from these reported framework, any kind of a best practice in Iraq that they are pursuing this and documenting their efforts toward a better AMR control from your experience?
Yes.
Is there like a national database or an institutional database where they are compiling these reports? Or maybe they are using them for research purposes?
As I mentioned in the presentations, Iraq started because we have focal point at the AMR unit at the Ministry of Health, Department of Public Health. We have focal point about AMR with the WHO. We started to collect data in 2020. We have national report, 2021 national report, and 2022. This is the last one I am aware of. They may have the new one, but usually they wait until the end of the year to collect all the data and to get the report. So we didn't have, until recently, we didn't have national guideline, but I'm aware of that Minister of Health is working on a guideline to treat infectious diseases. Rely on these reports. So I expect very soon those guidelines will emerge, national guideline. But the question is the percentage of compliance. We still need collaboration between physician, because physician is the prescriber. We need to convince the physicians about the national guideline. We have this bacteria in general. So if you need to prescribe empirical treatment, please prescribe this antibiotic. According to our results, these are the best antibiotic can be prescribed empirically. So I think that the next step is to have good workshop with the physician, because they are the #1 prescriber. And in Iraq, pharmacists, they don't have the right to prescribe. They have only the right to review their prescription and to give recommendations. But those recommendations, they are not obligatory. So we need collaboration with from the physician as well. I know they are the expert, they know, but also they need to look at the national guideline. They need to look at our HONAT national report, because we may have different species. We may have different results than the, for example, American guideline. So I think relying on our results is better than relying on the international results.
This brings me to my last question, sir. Are there any list or items, or let's say priority research topics related to AMR in your perspective in Iraq that can be an area of focus for those researchers that we would recommend for academicians or for any international body or a clinical body that are interested to do research related to AMR, which can bring more solutions to the table?
In terms of research, I'm a faculty member at the University of Baghdad College of Pharmacy. We have graduate students. Our last master students, we have a couple of them working on antibiotic prescribing. So the topic, it's really under research. We have some theses written about AMR prescribing emerging. So far, I have 2-3 publications about AMR personally. I have 2 reviews. One of them, the literature review, I just summarized. It's accepted by the WHO Mediterranean Journal, and hopefully to be published soon. And we have recently, like few days ago, we have another review also published about the point survey of antibiotics. I think we are working on the antibiotics, but in terms, I can say they are usually local studies. I think it's better if we have international experts. I think if international bodies can help our local researchers, I think we can get high quality research, because now we rely on our expertise in the area, and always collaboration is better. So I think if we can get collaboration, we are welcome any kind of collaboration from ISoP, from WHO, because we need to bring the international expertise to this area, and to always our goal is to raise awareness about the alarming situation we have in Iraq. Now, I heard from some colleagues, we have some patients, they have septicemia, and unfortunately they died because we had no antibiotics can work against those pan-resistant bacteria. Imagine, and we have people dying from infectious diseases in 21st century. So it's very bad news, and we don't need to lose our loved ones due to infectious disease, which should be, we overcome this infectious disease should be like decades ago. Now we have alarming situation in Iraq. We have very high resistant rate, and we don't have very new antibiotics. We have few of them, but unfortunately those antibiotics, they have high rate of adverse events, so we cannot use them regularly. So we welcome international collaboration. We welcome any workshop. We welcome any research collaborations on behalf of University of Baghdad College of Pharmacy, Minister of Health, and all the organization in Iraq. We always keen to collaborate. We always open our doors because we need to help our people, and also we need to give our experience to the international, because we are one community, we are one health, and we need to improve the health of our community. Thank you so much, Dr. Hassan.
Thank you so much, Dr. Ali. I will say that this is the call to action to welcome everyone for collaboration using this platform, and which is one of the purpose of this meeting is to highlight potential collaboration. Thank you again for your presentation, and allow me to move on to the next speaker for this session. We have now let me introduce to our next speaker, Dr. Zeina Nuruddin, who will present the WHO role in addressing AMR with specific examples from different contexts. Zeina Nuruddin holds a master's in public health and health promotion from Brunel University, and a master in clinical biochemistry from the College of Medicine in Baghdad, and a bachelor degree in pharmacy from Baghdad College of Pharmacy. And she's a specialist pharmacist that devoted her practices in strengthening main key topics in pharmaceutical sectors during emergency, where main areas comprising components of national medicine policy, including medicine selection and use, medicine supply system, medicine pricing and financing, medicine quality control and assurance, in addition to AMR One Health initiatives. Zeina has effective international background in developing projects that promote health system and facilitating the coordination and implementation of national action plans in different public health topics, support in developing the required policies and guidelines in areas to improve the susceptibility to safe, qualified, and affordable medicines. Dr. Zeina, the floor is yours. You may start your presentation.
Thank you, Dr. Hussam, for this presentation. Just confirm if you can see my screen so that I can go ahead.
Yes, it looks perfect.
Thank you very much. Thank you very much. Welcome, everyone. Thank you for joining us today in this online session. I am very excited to have you all participated in this online effort. Before I start my topic, welcome everyone. Thank you very much for participating today in our online event. Today, our presentation this online video. This is about WHO online event for raising awareness about the threat of AMR, and also the optimizing the use of antibiotic. So this video is a call for action to raise this awareness through it's conveying the key messages about the best practices for WHO. So please have a moment to take through this video. Can you see my screen? Colleagues, if there's an issue in the online, can you hear me?
Yes, doctor, we can hear you.
Yes, and can you see my screen, please?
No, yet.
Now?
No. Now we see in slides mode, not presentation mode.
Okay, now, please.
Yes, yes.
Okay, thank you very much.
Thank you, doctor.
So I will go through the online video. This is WHO newly launched video campaign about raising awareness. WHO is raising awareness through a special event that is conducting in every year in November. So for this year, it will be from 11th to 24th of November. And this video, it's a call for action for all of us to participate in raising the global awareness about the antibiotic use and promote the best practices for rational use of these antibiotics. So the video is conveying key messages about WHO global effort for raising awareness and also engaging all of you to participate in this effort. So without any further delays, please have a moment to listen and to watch this video.
Every year, antibiotics and other antimicrobials save millions of lives. But the more we use and sometimes misuse them to treat bacteria, fungi, viruses, and parasites, the more they resist them.
We call this phenomenon antimicrobial resistance, or AMR.
AMR is when the medicines that were designed to treat infections no longer work. It can lead to lifelong struggles or even death.
Without effective antimicrobials, a single infection can become life-threatening, even if you're young and in good health.
AMR can take many forms. A minor skin wound that becomes impossible to cure.
A routine surgery that exposes your body to dangerous microbes.
An infection you acquire at the hospital. Antimicrobial resistance, or AMR, is invisible. I am not.
Join us. Raise your voice.
Together, we can prevent AMR.
So raise your voice and participate in our effort to raise awareness about it of AMR. WHO is taking the lead. Sorry. WHO has taken the lead in this technical issues. WHO has taken a leading role in the global effort to address the threat
If
of
you allow me,
AMR.
Dr. Zena, can you
Yes.
share the slides? Because it's not shown.
You cannot see my slides?
No, just try sharing the screen again.
Okay. Please confirm if you are seeing my screen.
Yes, now we can see it. Can we try and make it full
Okay,
screen?
and this is now? Is that okay now?
Yes, perfect.
Okay, thank you very much. So WHO has taken a leading role in global effort to address the threat of AMR. Since 2000, 2015, WHO called for developing global action plan, which provide a framework for countries to develop their own national action plan, focusing on 5 strategies that's strengthening awareness and improving the knowledge in community base, strengthening the surveillance and research. In addition to that, optimizing the use of antimicrobial agents. Moreover, WHO also help countries to develop the required technical guidelines and tools. For example, WHO Global Stewardship Program. In addition to that, IPC, Infection and Prevention Control Program, besides direct support through providing the required trainings and capacity buildings in different aspects, especially in countries with low and middle income countries. Of course, the awareness and education training, as you saw 1 minute before, the awareness campaign, the WHO every year is supporting countries to develop the required materials that can be tailored or targeted either community-based or health sector to raise the global awareness about the threat of AMR. Beside that, of course, the most important is the technologies and the evidence-based data. Many of the platforms have been developed like GLASS, which is the global antimicrobial surveillance system. And I will familiarize you with this global system that can give an eye for the countries to understand the threat of the infectious disease and also to analyze the data and to plan according to the available evidence-based approach. Of course, this is not only health aspect. No, it's a collaboration with the other organizations. WHO is leading even the coordination with different organizations who they are related to the topic of AMR, like Food and Agriculture Organization, World Animal Health Organization, besides the civil society and different other partners and governments who they are having a key role in addressing the threat of AMR. So here, these key facts. AMR is considered one of the top global public health issues, and almost the bacterial 7 billion global deaths in 2019. The most driver for this was the misuse and overuse of the antimicrobials, not only in human, but in animals and plants also. This, of course, put us in a critical situation of developing drug-resistant pathogen. And definitely this will put us on further burden, financial burden, as it's estimated about 1 trillion additional healthcare costs maybe by 2050 will be spent only to find research or identify the best antibiotics that can be balancing the effectiveness with the adverse event. Below you can see that the theme for this year is about educate, advocate, and act now. And this is a message for all of us to work on this global topic. Definitely this event is occurring, as I mentioned, every year in the 3rd week of November. And for this year, it will be from 18th to 24th of November. So as I mentioned, of course, database management is very important. And to have like an eye about what is happening in the country level is very critical for any decision making. You can see here the Global Antimicrobial Resistance and Use Surveillance System, GLASS. This platform has having a lot of data coming from either from routine data surveillance or from the focus surveillance or from the studies and surveys that regularly happening for different areas, for example, the burden of the disease or maybe One Health approach and so on. From the right side, you can see how many countries have been enrolled so far, either in antimicrobial resistance surveillance system or in antimicrobial consumption. So in blue, you can see the countries where they are already enrolled in the system so far. while in the purple, it will be only the countries who they are enrolled in one platform, which is the antimicrobial surveillance system. A few of countries still not enrolled, but hopefully by end of 2025, the whole countries can be involved in this platform and can help, of course, in global efforts to address this threat. Of course, if you need any further information, you can have all this data available on WHO website as the below link. So today I will give two examples from the Eastern Mediterranean region to just elaborate more of the WHO platform and the participation in terms of giving evidence-based data. So WHO, for example, enrolled in Myanmar in 2017. And since that date, WHO started to analyze all the data from the countries. From Iraq, you can see now for different infectious disease. I will present the results for the bacteriologically confirmed infections and antibiotic susceptibility test result in different disease platforms. So today I will present for bloodstream, in addition to that, urinary tract, to understand more where we are in terms of multi-drug antimicrobial resistance development. So here from these graphs, you can see from the left side, the frequency of the bloodstream pathogens, who they are responsible for bloodstream infections, Salmonella, Staphylococcus, Acinetobacter, and so on. And on the right hand, you can see what kind of antibiotic have been used on the public sector so far to treat these pathogens. Resistance. So you can see that most of the antibiotics is already developed resistance to this pathogen. Of course, if you notice that these antibiotics is not all of them, they are from the first generation or access group, but there are different aware classification, antibiotics have been used and resistance have been developed. So this has put us in very critical situation, and of course for the country to take immediate actions, strategies to elaborate or to contain this thing, and also to have more control about the kind of antibiotic used in public sector in addition to the private sector. So here another example for the infectious disease that are responsible for urinary tract infections. You can see Escherichia coli and Ecclebsia pneumonia. And on the right side, you can see the antibiotics who they are developed already resistance for treating these pathogens. Another example or the benefits of the platform that are have been developed by WHO to help the countries is the antimicrobial consumption data. And I give example today from Egypt. Egypt have been enrolled in 2020, and they feed in this platform the data from a period of 2016 until 2021. So here you can see this country is almost, they are using less than 60% of the antibiotics is from access, while the percentage is almost 40% is from watch and less percentage for reserve. On the other hand, you can see they are most reliable on the oral kind of antibiotic rather than the parenteral or inhalation and rectal dosage form. Of course, this is there is a lot of misperception that the parenteral is more effective than the oral, but the reality, both of them, they have the same effectiveness and no difference in terms of the if the parenteral is more effective than oral. This will elaborate more about that the route of administration, whatever, it's have the same effectiveness. So before I end my presentation, I want just to highlight the main pillar who they are responsible for the for addressing the threat of AMR and optimizing the use of antibiotic. So from this graph, you can see the national or strong national regulatory authority, it's very mandate to establish the required regulations in terms of approvals of the antibiotic that should be available in the country based on the country context of public health disease status. Depend on the, of course, regulations for the procurement, regulations for the use of these antibiotics, and even to have more control on public and private sector. Another approach, which is the supply chain management, that can ensure the availability of the most effective and cost-effective antibiotics in both level or in country level, not forgetting the accessibility of these antibiotics. This is have two approach. The first one, that the availability of the right antibiotics for patients who they are on need in terms of matching the diagnosis with the right dosage form and correct dosage regime. On the other hand, restricted availability of these antibiotics for non-scientific use of these antibiotic, like what is have been seeing in the private sector. Antibiotic use, so the best practices for using the antibiotic use according to the scientific guidelines, and using the cultural sensitivity test and all the approach that can help the health staffs to take the right decision when prescribing any kind of medication, including the antibiotics. Having an eye about what is happening in terms of trend of the pathogens or the antibiotics consumption. So we need strong surveillance system for capturing all these data to understand where we are in terms of strategies, in terms of monitoring and follow up these strategies. Of course, prevention measures can be achieved through a perfect immunization program. So if it is possible to prevent the outbreaks or the diseases that can be prevented by immunization, of course, vaccination is the best approach rather than treating and using such kind of antibiotics. Last but not least, the IP is an important pillar to minimize the hospital-acquired disease. And of course, in general, all these efforts is not only on levels of human, but also on the levels of plant and levels of animals. So this is multi-sectorial actions that should be approached on country level to achieve the best results for optimizing the use of antibiotics. On the other side, you can see the WHO aware antibiotic book list. This book list have been launched in 2023. It's helping the countries where they don't have standardized treatment guideline to, especially in emergency context, to help the health staff to educate about more the first choice treatment recommended by WHO. And if you already have the chance to look at this guideline, you can see WHO targeted almost 22 diseases on primary healthcare level, 12 diseases on secondary healthcare level, and the whole guideline, you can see it's rely only on 5 or 6 antibiotics, which is mainly from access group. What is the meaning of the access? The access, it means the antibiotics that have narrow spectrum of activity with good effectiveness and less or minimized side effect. While the watch, it should be used when there is more clinical severe clinical manifestation, and if the antibiotics are already resistant or the pathogen, sorry, is resistant to the antibiotics who they are from the access, while the reserve, it's the last choice, and this is can be only used when we have multi-drug resistant. Of course, this guideline is available in the WHO website in English and in French, but now we are trying to work with the regional to have also Arabic version. If you have any questions or if you need it in Arabic, please don't hesitate to communicate with us This is my contact, and thank you very much. Over to you.
Thank you so much, Dr. Zeina, for this interesting presentation and a comprehensive one as well. I would like to encourage everyone to use the chat box to write their questions. And until then, I have a couple of questions. In terms of the strategies that WHO adopt or support countries in the region, like the aware classification, what is WHO experience and compliance with these guidelines? Are there variations in compliance with the adoption of such strategies? And how does WHO tailor its strategies based on the context of each country? If you can share with us some insights.
Thank you very much, Dr. Hussam, for this interesting question. Actually, yes, WHO, when they are trying to develop the required guidelines and tools, of course, it's encouraging all the countries to use these guidelines. However, through engaging the stakeholders in webinars, in also workshops to familiarize them with the available guidelines and the recommended strategic approach that they can follow, WHO is trying to work with all the stakeholders to understand what is the kind of challenges that may they face to implement such kind of guidelines in the countries. Yes, there is a lot of challenges in terms of weakness in the monitoring and supervision follow-up, and this is one of the components, even as a WHO want to in near future to focus on. Strong national regulatory authority is the most important in countries to follow any guideline, any recommendations that can be comes from WHO or even from governmental to ensure the optimizing use of antibiotic in the countries. Over to you, if I could manage to give you a clear answer for this.
One of the colleagues actually discussed the use of levofloxacin. Some agents in the classification of the aware classification can act, or sometimes they need to be reconsidered in terms of a country practice or a certain practice in each country. Would WHO help in reconsidering classifications in the aware guidelines, and in what situation does that happen?
Okay, thank you very much. Actually, WHO, when launched this guideline, it have been take a lot of process of consulting with the experts and professionality from the whole world to understand what is the best in terms of data or evidence base for the developed antibiotic resistance. However, of course, there is no standard that can be rely on for whole or until the end of the for example 10 or 20 years. It depends on the global public health update about the infectious disease, about even these data that are available on WHO online platform can help them to revise the guideline and also to update the guideline according to the trends of the infectious disease and the emerging pathogen. So there is no how I can say resistance to change, but it's a matter of updating the public health context. So if there is any evidence-based that can help WHO in take this decision, definitely WHO can consider the revision and also the updating version.
Thank you so much. Allow me, Dr. Tamer Shumari is raising hand.
Yes, thanks, Dr. Hussam.
Thanks.
Thanks, Dr. Zeina, for sharing your knowledge. It's really an experience. Really, I mean, when I was listening to you, you really opened several questions in my mind, and all efforts that you guys are doing within the WHO. Really, thanks for all these efforts. But one of the main concerns that we have, especially in the Middle East, specific. Actually, more than one. The first one is the way of how we are dealing with the antibiotics, antifungal, and a little bit with antivirals. Some countries they have it can be prescribed by anyone in the community pharmacy. They don't need to have a prescription. Lead to error. I'm sorry, resistance, which is ultimately will be impacting the patient safety and diagnosis. The other one, it's the healthcare professional themselves. They do not really, in general, not all, they do not really understand the danger from using the antibiotics for any disease. So, what do you think is WHO, or from your experience in general, how can we fix these things? First, prescribing the medications without prescription in some countries. And the second point is enhancing the healthcare professionals. And here in specific, talking about physician, pharmacists, nurses. So if can hear from you, Dr. Zaina, that will be great. Thanks.
Thank you very much, Dr. Tamer, for this question. Actually, the first part of the question is mainly relying on the country itself to have strong national regulatory authority. Because if you have strong national regulatory authority, this will help in managing and controlling the antibiotic use, not only on the public sector, but even in the private sector, in terms of even approval for these antibiotics to be available in the countries through the procurement process, through the description, and even prescribing these medications. So one of the things that I think is promoting the awareness about the importance of using the antibiotic through like weekly, monthly, and even maybe annual events that can update the knowledge of the doctors, especially who they are newly graduated. In addition to that, they have like higher specialty. Maybe they have more complicated understanding, and they are just believe that their thoughts and what they already learned is the correct approach. But through trying, because honestly, any change from the beginning, it will be difficult. But if you are working on that step by step, first of all, by promoting the regulations that can control the use of the antibiotics in the private and the public sector. This is first. Promoting the monitoring and supervision through the surveillance data, through the consumption data, through other platforms that can help the government to take the required decisions, and to work on the awareness, education material, not only on health sector, but also in the community. I can give you example for this guideline, which is WHO launched guideline. I received a lot of objections from the doctors themselves about the first line recommended, and they are always saying it's not working, it's not good in terms of resistance, and we are facing a lot of problem with the patients. But then you should understand the main reason for that. First of all, when they are the doctors, they are mentioning this kind of challenges. Are they did culture sensitivity for the patients before they are even trying to judge the antibiotic itself? This is the first thing. So the lack of surveillance or the lack of culture test in the hospitals or in the lab facilities, it's very mandate for the doctors to help them to take this decision. The second thing is about sometimes the doctors, they are just afraid from the patient because of the overload, because of their reputation. There is a misconception that if they didn't dispense antibiotic, this is mean that this doctor is not good, and they will try to change the doctors to the next and so on. But anyhow, this is need a very strong collaborative effort from all the health sectors, not only on the level of public, but even on the private, from the governmental side, and even from all the other sectors, from like animal sector, from plant sector, to work to optimize the use of the antibiotic, to raise more awareness. And one of the examples is WHO event. Every year, WHO is trying to work with the countries to work on activities, education, developing education materials that can tailor either on the health sector staff level to not educate them, but just to remind them about the importance of the threat of the AMR, and how it is the best practice to minimize or their actual role in minimizing the threat. If you are going with data, with evidence-based, trust me, they will be the first one who are afraid about prescribing any medication. And this is from one of the examples that have been recently implemented in Northwest Syria. I got a lot of challenges in implementing the WHO guideline, but then with the evidence-based, with the data, with the kind of messages that need to be tailored toward this kind of level of health staff, then I could manage to convince them, and thanks to that, they started even to implement it in their health facilities. So hopefully, year by year, the change will be, I know it will be slowly, but at least there will be a change, better than nothing. Over to you. Thank you very much.
Thank you so much. I'm kind of biased to pharmacists, so this question is for pharmacists. How would WHO would be interested to support national programs for capacity building of AMR for pharmacists? I believe that pharmacists are accessible, and they are playing a good role in consulting and providing recommendations for medications in different settings in hospitals and community pharmacies. What do you think of the vision of WHO in supporting programs that are dedicated for pharmacists to make them equipped, qualified, and certified in providing recommendations related to antibiotics and infectious disease in general?
Thank you very much, Dr. Hussam. This is a very important question. It's not about that you are preferring on pharmacist level, but actually the pharmacists, honestly, they are the entrance point for getting any antibiotic, either from the private sector or from the public sector. So if how I can say the syndicates, even the Ministry of Health or the universities work toward encourage the pharmacy or the pharmacists to understand their role in the aspects of AMR, I think this will be change a lot and will give more control on the dispensing and misusing of the antibiotic. So yes, I agree with you that it's important to work on providing the required curriculum, the required education, the required even roles and responsibility for the pharmacists in terms of the threat of AMR. So definitely WHO is working toward engaging all the health sectors they may have role in minimizing such kind of misuse. But again, I agree with you that the pharmacists, they should have take more role in advising, in taking lead for accepting or even refusing, even to discuss with the doctors in terms of if the diagnosis is matching with what have been prescribed, to be aware about the best or the recent data in terms of standard treatment guidelines, in terms of recommended global guidelines for antibiotic use. Thank you very much.
Thank you so much. Allow me to Dr. Samer, he has a follow-up question.
Yes, thanks, Dr. Hussam. I don't want to let this opportunity having Dr. Zaina with us without having some more questions. So, Dr. Zaina, you mentioned about the Medication Safety Week that's usually run by the WHO. So there is a possibility that, like what's happening in Europe, usually they get together and work on something there for enhancing the medication safety and specific, or in general. Is it possible to do something like this here in the Middle East, like either under the umbrella of ISoP Middle East chapter or ISoP or whatever? At least if we could do something like collaboration between like the most, let's say, the most active countries or members or whatever. So if that's possible, this will be really great.
Thank you, Dr. Tamer. Actually, yes, WHO always working on the concept of having a good coordination and even one approach for all the region. If you know about the APSALA Monitoring Center, the APSALA Monitoring Center is one of the collaborative center that WHO work with WHO in terms of safety and even reporting any adverse event or adverse effect from the medications in general, of course, including the antibiotic. So yes, this approach is already available, but maybe it's not achieved the highest level of having one platform for the whole region. But maybe, of course, with the coming years, there will be more and more collaborative work, because at the end, even for any adverse event or side effect of any medication, should have like a global alert and should have platform data managing from different countries and from different aspects, so that WHO and even the countries can take actions accordingly. Over to you. Thank you very much.
Thank you so much, Dr. Zena, for this interesting and enriching presentation and participation. I think we have come to our conclusion remarks. So thank you so much, everyone, for all of you and our speakers for your invaluable time and contribution to making this webinar and Patient Safety Day even possible. I would encourage everyone to join us in the next and upcoming session for more presentation, which will come from the Africa region and will begin in 16 CET time. And you may visit ISoP online Facebook page or the YouTube channel to view this webinar or any other webinars from this Patient Safety Day event again. We will publish the records from this event in the next few days. And on behalf of the International Society of Pharmacovigilance, thank you so much for your participation today. Thank you so much.
Hello, I am Angela Caro. I am the president of the International Society of Pharmacovigilance, ISoP. And ISoP is a society of pharmacovigilance who works in how to improve the medication safety in the world. We have presence in more than 100 countries, and we are very proud about what we are doing and the society. We have more than 14 chapters. It includes chapters of Africa, China, and North America, Latin America, and other regions. And we are organized by special interest groups too. We have some groups like We Are World Evidence, like medication errors and herbal and traditional medicines, and risk communication, and other groups. We have some meetings that are the perfect excuse for meeting with some people that work in the same field that we work. For example, we have the mid-year symposium each year, and we have the biggest event in pharmacovigilance in the year in the world is the annual meeting. In the annual meeting, we have some conversations with experts who work in pharmacovigilance in different topics. We have session for each SIG, and we have the possibility to present some abstracts and oral presentations. We have events with more than 400 posters, and it is so useful for people to show his work. I think that being a member of ISoP is so important because you could build knowledge and you could share with partners about the topic that you are working in pharmacovigilance, and it helps a lot of people. It helps the patients, it helps the communities. We work with regulatory agencies, we work with WHO, we work with other people who is involved in education safety. Then please join us, see more about us, go to our webpage, and for sure we will find something for working together. I am the president of the International Society of Pharmacovigilance, ISoP. And ISoP is a society of pharmacovigilance who works in how to improve the medication safety in the world. We have presence in more than 100 countries, and we are very proud about what we are doing and the society. We have more than 14 chapters. It includes chapters of Africa, China, and North America, Latin America, and other regions. And we are organized by special interest groups too. We have some groups like real world evidence, like medication errors and herbal and traditional medicines, and risk communication, and other groups. We have some meetings that are the perfect excuse for meeting with some people that work in the same field that we work. For example, we have the mid-year symposium each year, and we have the biggest event in pharmacovigilance in the year in the world is the annual meeting. In the annual meeting, we have some conversations with experts who work in pharmacovigilance in different topics. We have session for each SIG, and we have the possibility to present some abstracts and oral presentations. We have events with more than 400 posters, and it is so useful for people to show his work. I think that being a member of ISoP is so important because you could build knowledge and you could share with partners about the topic that you are working in pharmacovigilance, and it helps a lot of people. It helps the patients, it helps the communities. We work with regulatory agencies, we work with WHO, we work with other people who is involved in education safety. Then please join us, see more about us, go to our webpage, and for sure we will find something for working together.
morning, good afternoon, good evening, everyone. Thank you all for being here with us today and for making this event happen. On behalf of the International Society of Pharmacovigilance, ISoP, we are very pleased to welcome you all to the 5th edition of the ISoP Patient Safety Day event that will be held today, September 12th, and tomorrow, September 13th, 2024. My name is Comfort Ogar. I am a Senior Pharmacovigilance Manager with the United States Pharmacopoeia. I am based in Rockville, Maryland, and I am the current president of the Africa chapter of ISoP. I am delighted to host the Africa session of this year's Patient Safety Day. Now, the World Health Organization established a dedicated Patient Safety Day to increase public and patient engagement in healthcare safety and to promote global action to prevent, reduce avoidable harm in healthcare. This year, WHO has chosen the theme, Improving Diagnosis for Patient Safety, using the slogan, Get it right, make it safe. ISoP affirms the objectives of the WHO Global Patient Safety Challenge and calls on all stakeholders and health professionals to prioritize and take early action in critical areas associated with significant patient harm due to unsafe medication practices. These include high-risk situations, transitions of care, polypharmacy, look-alike, sound-alike medications, and other serious disruptions in the provision of health services. Now, as we start today, we will listen to our president, Dr. Angela Caro-Rogers, while she addresses us in a few words. Please sit back and listen to Dr. Angela. Thank you.
Hello, I am Angela Caro. I am the president of the International Society of Pharmacovigilance, ISoP. And ISoP is a society of pharmacovigilance who works in how to improve the medication safety in the world. We have presence in more than 100 countries, and we are very proud about what we are doing and the society. We have more than 14 chapters. It includes chapters of Africa, China, and North America, Latin America, and other regions. And we are organized by special interest groups too. We have some groups like real-world evidence, like medication errors, and herbal and traditional medicines, and risk communication, and other groups. We have some meetings that are the perfect excuse for meeting with some people that work in the same field that we work. For example, we have the mid-year symposium each year, and we have the biggest event in pharmacovigilance in the year in the world is the annual meeting. In the annual meeting, we have some conversations with experts who work in pharmacovigilance in different topics. We have sessions for each SIG, and we have the possibility to present some abstracts and oral presentations. We have events with more than 400 posters, and it is so useful for people to show his work. I think that being a member of ISoP is so important because you could build knowledge and you could share with partners about the topic that you are working in pharmacovigilance, and it helps a lot of people. It helps the patients, it helps the communities. We work with regulatory agencies, we work with WHO, we work with other people who is involved in medication safety. Then please join us, see more about us, go to our webpage, and for sure we will find something for working together.
All right. Thank you so much, Dr. Caro, for your words of encouragement, and thank you to our audience for your attention. So we also encourage you to share your experience at this event using the hashtags #ISoPOnline PSD 2024, #ISoP Medication Safety, #ISoP Medication Error, MEDERROR, MEDERR, #ISoP Medication Without Harm, and hashtag ISoP Patient Safety Day. And then please feel free to publish your pictures and any ideas you have for engaging patients this day. And as we continue to celebrate the Patient Safety Day onto September 17th. So let me introduce our first speaker for today, who will be speaking to us on assessing drug-gene pairs to support the development of Africa-relevant, physiologically based pharmacokinetic models. Our first speaker is Dr. Tracy Harrell. Dr. Harrell completed a PhD in pharmacology at the University of Pretoria, while also attending the University of Cambridge as a Commonwealth Scholar on a split-site PhD. She then spent 2 years as a postdoctoral researcher in the section of pharmacogenetics, Department of Physiology and Pharmacology at Karolinska Institute in Sweden. Currently, she is a senior researcher in the chemicals cluster at the Council for Scientific and Industrial Research in South Africa, where a key focus of the group is increasing the representation of African genetic ancestry in global health resources. Her focus is on developing and characterizing contextualized cellular models with a specific focus on induced pluripotent stem cell-derived liver cells, primary human hepatocytes, and liver tissue biopsies for pharmacogenetics and liver disease studies in Africa. We're so delighted to have Dr. Harrell today. Dr. Harrell, the mic is all yours.
Thank you, Comfort, for that very kind introduction. We'll just share my screen and make sure that everyone can see before we get started. Fantastic. So good day, everyone, and thank you very much for the introduction, Comfort, and thank you to the organizers for the invitation to speak at this session. As Comfort mentioned, I'm a researcher, and my background is predominantly in the development of physiologically based models of the liver to address questions unique to the African continent. And today I will speak briefly about the relevance of physiologically based models and the genetic representation of these models as they currently stand, and then discuss some of the findings related to the implementation of PGX to understand the development of these very specific models. We do not have to belabor the point that Africa has the greatest human genetic diversity in the world. It is well known, and we can see that represented here by the lighter shades in this figure. Research on the Human Genome Project revolutionized biomedical research, which serves as the cornerstone of modern medical research. However, a lack of adequate population genetic diversity in these seminal research efforts, such as the Human Genome Project, have propagated inequalities in the provision of healthcare across the globe, especially in historically underrepresented regions such as Africa. And while Africa houses this great genetic diversity, African genetic diversity is not equitably represented in clinical trials. And despite the number of clinical trials continuing to increase across the globe, Africa, seen here in the blue, represents only a minor proportion of these trials. And this has major implications for the safety and efficacy of drugs which are prescribed to patients on the continent. A 2016 survey in 4 hospitals within South Africa found that approximately 9% of hospital admissions could be related to adverse drug reactions, with the finding that approximately 54% of these are considered preventable, which is a major issue when it comes to patient safety on the continent. In a similar way, African genetic diversity is also not equitably represented in basic scientific research, which creates another issue. When we're looking at the representation of African genetic diversity in genome-wide association studies, in this graphic, we see here on the right-hand side, the global population represented in billions, where the purple represents the African population, which constitutes approximately 80% of the population. However, when we look at the representation in genome-wide association studies, we can see that this equates to about 2%, which shows a disparity which needs to be addressed. And when we see the population, European populations represented in the red as proportionately overexpressed, we can understand that the medications potentially being derived have certain issues. When we look further into cellular resources, which is predominantly what the work that I focus on, we see that African genetic diversity in resources such as human embryonic stem cells and induced pluripotent stem cells are also underrepresented, here seen in yellow. So we have these compounding effects of not being well represented when looking at drug discovery and development. The global scientific landscape is, however, voicing with urgency the need to address this, and there are publications ranging from Nature through to Cell, where people are beginning to speak about the inclusion of diversity in basic sciences, preclinical models, drug discovery, as well as clinical trials. So a lot of the work that we do works at an intersection of preclinical modeling and then understanding what is happening within the clinical landscape. So based here in South Africa, when we talk about physiologically based pharmacokinetic models, the liver is a central organ system to model due to its relevance in drug metabolism and obviously the corresponding impact on drug safety. So why do we really care about modeling the liver? It is the most active tissue per unit weight, which metabolizes drugs. So it contributes to the detoxification, modification, and excretion of xenobiotics. And due to the liver's role in drug metabolism, it does contribute a lot to drug failure as well as drug withdrawal. And this is predominantly linked to the genetic variants in pharmacogenes, which have differences across population groups. And what is then important is that all of these things contribute to adverse drug reactions as well as inefficacy in patients. So a lot of the work that we do is looking at independent and interdependent preclinical models, which can be used to address translational and mechanistic issues that arise when we're looking at patient safety, and potentially use those as a bridge to work on drug development and safety. So when we talk about preclinical models, what is it that these models are currently capable of doing, and can they really serve to bridge this gap that we're talking about? So some of the work that I have contributed to over the past couple of years is, for instance, this research on phyluridin. We see that drug-induced liver injury can be detected in physiologically based models. So one such example really is phyluridin, which was an antiviral nucleoside analog for chronic hepatitis B virus. And when it entered clinical trials, 5 of the 15 patients died due to hepatic failure and lactic acidosis. And during preclinical studies, there was no toxicity detected in animals, and even mice with humanized livers did not detect phyluridin toxicity. But if we look at these primary human hepatocytes, spheroids, exposed to phyluridin, we were able to detect not only toxicity, which we can see over a period of days and weeks when we expose to phyluridin, we're also able to deconvolve the mechanism of action of phyluridin in these models, which demonstrates the impact that these preclinical models can have when we are talking about assessing drug safety. In a similar way, these models are growing in their capacity to be utilized for modeling genetic variation. So this instance is not necessarily about drug-induced liver injury, but we're also able to see that genetic variation can be modeled. So in this instance, primary human hepatocytes were used that have a predisposing genetic variant, which predisposes to metabolic associated liver disease. And we're able to see that this TM6SF2 variant, when exposed to various concentrations of free fatty acids in order to model a steatotic phenotypes, it does have a propensity to have exacerbated steatotic phenotype compared to wild type. So we can use these models for mechanistic elucidation of disease progression as well as drug-induced liver injury. So as these models become refined and the fidelity with which these models is becoming increasingly evident, and therefore their utility in drug safety, and as a consequence, patient safety. So this kind of data brings us to a key intersection as to whether these physiologically based models are available on the African continent, and furthermore to a very important value proposition for the continent in conceptualizing an African hepatic modeling platform to both improve patient safety and clinical outcomes. So if we look at this graphic, which was published in a paper of ours a couple of years ago, we speak about stratified drug patient pairings and improving clinical outcomes. And this is on the trajectory towards personalized medicine, which is the hope for not only the continent, but for the globe. And this kind of outcome requires integrated input from both the pharmaceutical industry as well as African regulatory authorities, in our instance in South Africa, that is SAHPRA, who would be able to utilize information created from an hepatic modeling platform to help support this stratified drug patient pairing. So here we would imagine several preclinical resources, such as cell lines that represent African genetic diversity, primary human hepatocytes, as well as induced pluripotent stem cells, which can be used to begin to actualize this value chain. And each of these model systems is different in their fidelity to answer questions about drug metabolism, as well as about the inference to patient safety. But importantly, in an instance like this, we require information from the clinical landscape to inform the competencies of these models, to make sure that these physiological models have the utility to understand what they might contribute to patient safety in the clinic. So we work on both aspects of the preclinical modeling, as well as, in some instances, some clinical data, which is what I'll get to in a little while. But firstly, just to highlight that in addressing the gap in representation of African genetic diversity, there are groups that are working on generating these physiologically based models for sub-Saharan Africa. And the first such instance is the generation of human-induced pluripotent stem cells from individuals of Black African ancestry in South Africa. And here we just have a representation of what our human-induced pluripotent stem cells look like. They express OCT4, which is this stemness marker, and we're able to differentiate these into liver-like cells or liver-like tissue to ask specific questions related to drug metabolism. And in a second instance, within sub-Saharan Africa, we have the projects such as the African Liver Tissue Biorepository Consortium, which is set up to isolate primary human hepatocytes and human liver tissue microsomes from tissues from the continent to provide them as a resource for both pharmacokinetics and pharmacogenetic testing. So these resources, while very small in their numbers now, are starting to contribute to this underrepresentation of genetic resources in the preclinical landscape. So hopefully they can start bridging some of the issues that we see in the clinic. But again, we require information from the clinical landscape to inform the competencies of these models. So we can't just build physiologically based models as research tools without understanding their utility and application to ensure that they're relevant. So we need to remember that physiologically based models are really fit for purpose. They can answer specific questions. They are not an entire system. So we have to understand what they have the fidelity to answer and what they do not. So we need to understand the power of these models to position their utility to address priority research areas. So if we want to understand issues compounding drug inefficacy or safety, to assess whether these models could aid in addressing them, we've looked at assessing actionable drug gene pairs to support the development of these physiologically based pharmacokinetic models. And we've looked at that in a specific context, a local context, to begin to describe the granularity of the impact of genetic diversity on drug safety. So it is known to many, especially in this kind of field, that guidelines for actionable drug gene pairs are established by various consortia, including the CPIC and the Dutch Pharmacogenetics Working Group. However, only 15% of drugs with PGX guidelines are comprehensively investigated in African populations. And furthermore, the implementation of something like pre-prescriptive or preemptive genotyping is very much in its infancy on the African continent. So one of the most recently published studies, the preemptive pharmacogenomic studies, was the PREPARE study, which was initiated by UPGX. And it included 48 genetic variants for 13 pharmacogenes, including the majority of your actionable CYPs, where patients receiving a first prescription for one of more than 43 drugs was randomized into a standard of care or PGX guided prescribing. And when we read the study, we wanted to frame some of the information we had within South Africa in the context of this study. Because the study showed tentatively reported a 30% reduction in ADRs, and we wanted to frame the potential impact of PGX implementation in South Africa if we were to take these same drugs and drug classes and look at pre-prescription genotyping. So for some of this research, we had access to 4 years of dispensary data from this Deep Beaker Academic Hospital, which is a tertiary hospital in Pretoria and Gauteng here in South Africa. We also had, alongside that, individual case safety reports for adverse drug reactions from the South African Health Products Regulatory Authority that spanned data sets of about 3 years. We utilized some PGX gene-specific information that is publicly available. And what we did is we then framed the dispensary data and the ADR reports in the context of this PREPARE study. And we did that purely to prioritize certain pharmacogenes as well as drugs because there were so many to choose from. So, having a brief overview look at this data, we considered the number of individuals impacted by a specific drug class using prescriptions as a surrogate. So we have all of our drug classes that were present within the data set. We have the prescription numbers, so the ranking according to prescription numbers. We have the total costs, and then we just highlight the genes that are monitored within these specific drug classes. And when we look at the prescription numbers and the pharmacoeconomics of the drug, each of them has implications for framing implementation of pre-prescription screening. So from the drugs that were utilized in the PREPARE study, there were 29 drugs in our data set, which accounted for about 7,000 prescriptions, which is about 10% of the total prescriptions coming out of this hospital over that period. And this incurred a total cost of 33 million rand, which was about 9% of the total expenditure of the hospital over that period of time. There were 2 drug classes that did not come up in our data sets that were in the previous data sets, which were the antiarrhythmics and antihypertensives, and that's just because of medications being prescribed slightly differently. So these were not included in our data set. And what we observed when looking at these and breaking them down into respective drug classes is that when we looked at prescriptions, we had the highest number of prescriptions were for our analgesics, as well as our cholesterol-lowering drugs. When it came to expenditure, however, we had the highest expenditure was associated with our anti-cancer, as well as our immunosuppressive drugs. And we looked at various iterations of this data to try and build an understanding of the scale of prescriptions versus the expenditure, because how would we consider platforms for implementing this kind of information? So the key findings from our prescription data over the 4 years at a single tertiary public healthcare institute in South Africa was that we have 10% of prescriptions having actionable drug gene pairs out of this specific cohort. But interestingly, 3 drug classes, being our analgesics, cholesterol-lowering drugs, and antidepressants, specifically the TCAs, contributed to 76% of these prescriptions. And secondary to that, 9% of our total expenditure was associated with actionable drug gene pairs. And these were our immunosuppressives, anti-cancers, and analgesics, which contributed 71% of the total expenditure. So when we look at whether these, what we can see is that our actionable drug gene pairs are highly prescribed and incur proportional costs. And of course, this is by no means astonishing information, but it starts to build the case for implementation across disease or drug classes. So when we start looking at whether these drugs also have significant adverse drug reactions, it's very challenging, as many of you know, to assess the adverse drug reaction landscape on the continent, and South Africa is no exception. And even though South Africa is ranked as one of the highest reporters of adverse drug reactions for the continent, it really remains a small amount of total reports. So there have been papers such as that by Haynes, which demonstrate that the knowledge and practices towards reporting ADR is underscored by a large proportion of healthcare professionals not knowing how to report, which perpetuates a low frequency of ADR reporting. But despite these kind of caveats, we have to turn to ADR reporting data for South Africa and other countries in order to build our understanding of where there are issues which maybe preclinical models can start to intervene and develop mechanistic understanding. So the adverse drug reaction reports that we looked at over the span of 3 years, from 2018 to 2020, ranked efavirenz, unsurprisingly, as the drug with the highest suspected adverse drug reactions. And alongside that, we had our cholesterol-lowering drugs, atorvastatin and simvastatin, which alongside warfarin round up the top 5 suspected ADRs, drugs suspected of adverse drug reactions. And despite factors such as lack of reporting and missing data within reports, as well as things like inefficacy not always being recognized in a professional clinical environment, we can look at these ADR reports as well as their ranking, and this provides us insights into the potential for PGX for patient safety and where we might have to consider focusing our areas over the next couple of years. So drawing from this data, we need to highlight lessons from efavirenz when assessing the necessity for PGX. This is a well-known issue which does not have to, again, be belabored. And it has been discussed in the literature for almost 20 years, with kind of seminal papers highlighting the difference in allele frequencies between European and populations in sub-Saharan Africa, resulting in these neuropsychiatric adverse effects. But what we've noticed, what we've seen over the past 20 years, is that populations having adverse drug reactions was not enough to implement PGX because of the context in which PGX has evolved. So we've seen a reactive response to the replacement of drugs like efavirenz as a first-line therapy. And in doing so, there have been a lot of patients that have suffered as a consequence. So in the recent past, the second-generation HIV integrase inhibitor, dolutegravir, has been included in first-line therapy within South Africa, and it does have an actionable drug gene pair, but currently there's not CPIC guidelines. So if we look to the future, based on retrospective information within this context, do we have to how do we go about looking at potential drug gene pairs within the context of the African context that might be important to monitor in order to mitigate issues such as caused by efavirenz in the future? So when we've looked at our data, we have tried to conceptualize the understanding the scale of impact of these drug gene pairings within this very limited setting that we have been in. And the implementation of PGX at scale across the continent and even in South Africa is a daunting task. However, they are factoring in the number of individuals on certain drug classes, the pharmacoeconomics, and the prevalence of ADRs, we can start assessing the feasibility within unique clinical contexts around the country. So for instance, we have our cholesterol-lowering drugs, including atorvastatin and simvastatin, which contributed to 30% of prescriptions, which is a large number of patients, and a 10% expenditure. but it ranked the second highest in terms of adverse drug reactions. So this creates a priority for this drug class. We can see that the allele frequencies do differ between the European and sub-Saharan African populations, so it is something that requires cognizance within the African context. If we then look at a different drug class, such as our immunosuppressives, and we look at something like tacrolimus, it constituted only 1.5% of the prescriptions within our data set, but 28% of the expenditure. So because of the pharmacoeconomics, there is also a consideration for something like tacrolimus to be monitored for pre-prescriptive screening. Even though the number of ADRs is low, we have to consider within the genetic context that the allele frequencies for tacrolimus are extremely different in sub-Saharan Africa and the European population, and that transplant rejection is a severe outcome for these patients. So what we try to do is pull information that is at our disposal and say, how do we then categorize and prioritize for certain regions and specific populations that might be important. We've taken a step back very regularly when we talk about contextualizing our physiologically based models and try and understand if they can fill a gap. And if so, what is that gap? So if we briefly consider CPIC guidelines for drug gene pairs, they are designed to understand how genetic test results should be used to optimize drug therapy. And the prioritizing the order of writing these guidelines is based on several factors, some of them including the severity of the clinical consequence, so our adverse drug effects, which obviously, as I have alluded to, and many of you know, are very underreported. We also have how commonly used the affected drugs are and how common are the high-risk genetic variants. So we then have to consider, are there instances which require a concerted focus on the African continent to support prioritization? And can these physiologically based models bridge the gap for certain drug priorities on the continent? So we have to understand the context in which we want them to function. So one of these instances might be something like isoniazid and NAT2 for consideration as a priority area for Africa. Because it is used in tuberculosis therapy as well as isoniazid prevention therapy, we know that slow acetylated genotypes, which can be up to as high as 50% of certain populations, do contribute to drug-induced hepatotoxicity. But there are varied levels of evidence for NAT2 INH. So the published results, especially, I've highlighted 3 papers here, each of which have various outcomes which link genotype to phenotype. And because these evidence levels vary so much, it is not a priority for guidelines. However, if we looked at ADR reports as a subset for isoniazid, we had approximately 190 reports of ADRs as a suspected drug, and that would rank INH as 4th in our ADR listing. So despite it not having an actionable drug gene pair now, this is one example where the disease burden, the genetic variation, and the impact on quality of life need to be co-assessed to understand this prioritization. And as basic researchers, we need to look at whether or not these physiologically based pharmacokinetic models can provide sufficient evidence that it would change the prioritization of medications like this, or at least provide definitive information so that there's no longer this disparity in evidence base. So just to summarize, we know that the African population faces an extremely unique burden of disease, which is further compounded by diverse genetics, our unique environmental factors, socioeconomics, as well as fiscal constraints. So PGX implementation on the continent is imperative for drug safety, but how do we inform and prioritize preemptive PGX screening strategies? And a lot of the conversation we have locally within our teams is that we need to look at intentional and comprehensive investigations into regional and grassroots level dispensing, what is happening at the forefront of patients receiving medication. And some of what we are envisioning is that PGX implementation in Africa does not at the onset demand multi-gene panels, but that we need to harness contextual clinical-based expertise. So, for instance, an oncology center might realize great impact from focusing on CYP2D6 alleles, whereas a specialist organ transplant center would benefit from a CYP3A5 PGX strategy. So, focusing on understanding a specific individual context and implementing something as opposed to implementing nothing. And in the second instance, how do we inform the development of African relevant physiologically based models? And we need to prioritize this based on integration of clinical findings and model capabilities. And that is why this kind of brings us back to our value proposition of building an African hepatic modeling platform to develop African relevant physiologically based pharmacokinetic models. And in assessing the clinical data and information that is out there that is highly impacted by African genetic diversity or genetic variance, we not only support the development of such platforms by prioritizing certain applications, but we also build a potential roadmap for implementing PGX in South Africa. So I hope that this has contextualized for you the work that we are trying to do in South Africa at the Council for Scientific Industrial Research on both sides of the spectrum of being preclinically relevant in our models that we develop, and then also being cognizant and focused on the stratification of drug-patient pairings in order to inform that information. And with that, I just want to thank you all for listening to me today and thank the organizers for including me in this session. And I'm sure we will have some questions later on in the discussion. So thank you very much.
Wow, that was a fantastic presentation, Dr. Harrell. Thank you so much for sharing your work with us and for all the great work that is ongoing. You and the rest of the team are doing this. This is really, it's huge and it's big, and it's really impressive to see the amount of work that's going into this, because I think that is one area that we certainly have gaps in Africa. And as you mentioned, there's still a lot of work to be done, but certainly you're moving in the right direction and a lot of work is being done. So we're quite delighted that you're able to share your work with us today. So in the interest of time, I will move on to the second presenter, and then we can take questions after that. I would encourage our participants to please share your questions. You can write your questions down and then share them in the chat, and then we'll come back to take the questions and have some discussions before we close the session. So on that note, I'm delighted to introduce our second speaker, Dr. Jean-Marie Vianney Habarugira. I hope I got that right. He will be speaking to us on antimicrobial resistance and pharmacovigilance. Dr. Jean-Marie is a senior scientific officer at the Global Health EDCTP3 joint undertaking, where he coordinates key activities of the Science and Operations Unit. He's a pharmacist and has almost 15 years of experience in overseeing large-scale clinical research grants under each of the 3 EDCPT programs, EDCPT 1, 2, and 3. He manages a large portfolio of multi-country projects on clinical trials and research capacity strengthening, with a major focus on sub-Saharan Africa. In his doctoral research, he extensively studied the intersection between pharmacovigilance networks and antimicrobial stewardship strategies. And through his publications, he has proposed a set of tools that can be added to the antimicrobial stewardship strategies. As part of his work in epidemic preparedness, he represents Global Health EDCTP3 in international networks such as GloPED, where he serves in various working groups. Prior to joining EDCPT, he carried out research projects with KNCV Tuberculosis Foundation and the Dutch Medicines Evaluation Board. We are happy to have you, Dr. Jean-Marie, and please share with us the work that you're doing on antimicrobial resistance and pharmacovigilance. The mic is all yours.
Thank you. Thanks a lot for the kind words and the invitation. I'm hoping you are seeing my slides very well and you can hear me very good.
We can see you, but not your slides.
No slides?
Yet.
Okay. Let me then click that share thing again. What about now?
Yes, now we can see you. Would you mind putting it on presentation mode?
Let me do that. Is
yes,
it good?
now it's on presentation mode. Correct.
Okay,
Thank you.
great. Thank you. So I'll not repeat the title, but as you see, I'm going to talk about antimicrobial resistance and pharmacovigilance, two fields which are a bit far from each other, but as we've seen, or as already explained, seem to come close when we start talking about antimicrobial stewardship. So maybe just first of all, I would not go back to this chart, which for sure many of you have read, but just to repeat that this antimicrobial resistance crisis, it's a global crisis that we saw growing. We've seen it coming, and here we are trying to propose solutions with the scientific community, the politicians, those in businesses, those in pharma industry, everyone is involved. But today we are looking at it from a pharmacovigilance angle. That's why I'm mentioning this crisis in the context of what we know as inappropriate use of antibiotics, but also as today we are focusing on the African region, that laboratory capacity gap, which makes it difficult for some countries to implement antimicrobial stewardship properly. As we know, the WHO has a program for international drug monitoring, where we see this global collaboration to advance the practice of pharmacovigilance in countries across the world. And we, as a society, ISoP, we do follow the footsteps of WHO to make sure this pharmacovigilance as the science evolves and can help WHO and countries address some of these major problems. Now, I'm not going to go into teaching what pharmacovigilance is, but I'm hoping that everyone in the audience knows what MEDRA is, so the Medical Dictionary for Regulatory Activities. There we do know this classification that start from a system, organ, class to high level group term. But today I'm going to use a lot the word preferred term, the PTs. So this dictionary is used by regulatory authorities in the biopharma industry through a whole regulatory process from pre-marketing to post-marketing stages of a product life cycle. This MEDRA dictionary evolves every year almost. Just for the sake of this research that I'm going to talk about, I will just mention that we used the version 22 of MEDRA. I think now in 2024, we are already at, I'm not sure, maybe version 26 or 27. I'm really not sure, but just for those who may be working with MEDRA today, the version you are looking at is not what we use in this research that I'm presenting. Now, just a bit of story. The WHO Program for International Drug Monitoring goes back in 1968. But just to put in context my own research, in 2017, we got inspired by an Uppsala report, which, well, some of our colleagues, some PV experts were arguing that antimicrobial resistance is an overlooked adverse event. It was for the first time that I read that someone is looking at AMR as an adverse event that we used to report or hear about. Now, at the time, VGBase had over 20 million of ADRs being reported from more than 170 countries. And we did have this hypothesis that maybe within those ADRs in that database, there is something which can tell us something about this growing AMR and maybe something about irrational use of antibiotics. And maybe we can work from that to propose some strategies in the stewardship strategies. Now, we called it, we still call it the PV-AMR study, the study that we conducted, just to investigate that potential role of the worldwide network of pharmacovigilance database in the track of antimicrobial resistance. I'm sorry if you are seeing some clicks from people sending me messages on Teams. I hope it's not displaying there. Anyway, there was then these specific objectives to explore if those reports were, first of all, available, if they were available, but also to identify the limitations, the strength that we may have using these tools. Now, the database, the data source that we had, it was VGBase as global WHO database, and we went country level to use LAREP database from the Netherlands. Quickly, some of these things I'm displaying here for your information. When you receive the slides later, you can read these publications in detail. This was maybe just a case that we made where we were looking at this antimicrobial stewardship as a global problem, but also trying to propose the PV networks as another tool to add to the box. Some of the questions were, first of all, how big is the AMR data scarcity? It's a problem that we know that in some countries it's well documented, in other countries it's not well documented. But also we think about what can pharmacovigilance offer, knowing that the global PV network is a solid infrastructure. There is a skilled global workforce working to safeguard drug safety. And we do have a lot of individual case safety reports, which are not just reports, but contain a lot of information in terms of AMR if you look at antimicrobials. And then there was also this broader use of safety reporting codes terms, which we can work with. So there is also putting novel communication technologies to work if we think of sharing information from country to country. So after going through VGBase, we have published another paper on pharmacovigilance networks as an additional tool to the surveillance of AMR. You can look at the paper just for more details, but just a few things that I'm going to highlight here are these 17 preferred terms and corresponding MEDRA terms, MEDRA codes that we thought are AMR relevant. So classifying them, these 17, they fall into 4 categories. There were those related to resistance, those related to ineffectiveness, and those related to off-label use, and a few related to error of use. I'm not going to read all, but you can see if you start from, for example, from a PT called pathogen resistance, and it has a code, it says a lot about what has happened for that report to come to VGBase. I did manage to study reports that are related to 86 products, and on those 86 products from the globe, the whole globe, there were 15,000, more than 15,000, which we saw as AMR relevant. And those were being reported using these terms, these 17 codes that I was mentioning. And if we look at the system organ class, there were infections and infestations, general disorders and administration site conditions, injury, poisoning, procedures, complications. And again, we tried to classify these in those categories I was mentioning: resistance and effectiveness, off-label use, and errors. So just also to come back to that idea of data scarcity, but refocusing on Africa, when we looked at what was coming out of that data set, we realized that not much was coming from Africa, as much as we would have wanted to see how these ADRs related to AMR are also coming out of the countries that have maybe limited lab capacity. We have noted that, for example, if you look at amoxicillin, it's close to 1%. But if you look at maybe the biggest chunk of those reports, most of them come from Europe or the Americas. So drugs such as daptomycin, no report was coming from Africa, whilst maybe almost the majority was being reported from countries that arguably maybe have the better lab capacity, but also maybe better PV infrastructure to share and report the data. We went then to focus on country and looked at the LAREP, the database of the Netherlands, where we thought we looked at PV data as a trigger to identify AMR or inappropriate use of antibiotics that would ultimately lead to AMR cases. This was again to characterize ADR reports in the database of the Netherlands following use of antibiotics coded with any of the MEDRA terms from that list of 17, suggesting suspicion of resistance, ineffectiveness, off-label use, or medication errors, what we ended up acronymizing as RIOLE. Now, in 2015, then looking at that database from the Netherlands, there was a peak in what we were calling the AMR relevant reports coming to LAREP. The paper is published in Antibiotics. You can check the details, but those kind of details were giving us again an idea that this tool can be used at least to give signals, to give warnings that something's happening and deserves attention. And again, we looked at what were the most frequently used PTs reported in this data set per Riora group. And then we found that whatever was suggesting AMR was the majority. So those PTs that are called drug ineffective, pathogen resistance, drug resistance, they came in majority compared to, for example, PTs that were on product use in an approved indication. But all these, as they are classified here, they do show something about how this PV network can be used to tackle this growing global crisis. Here again, we revisited this classification that WHO has proposed, the AWARE classification, and looked at these PTs that were in the Dutch database, which AWARE classes were being affected. And you will see that the number of reports that were coming from the watch category were the highest majority. There were 50% were coming from tobramycin, Cipro, Azithro, and Moxi, a group which is classified as watch, compared to the reserve, which was 19%, and access 16%. But there are also some other combinations which were in minority. Again, this says a lot about combining the database in PV, but also what the WHO has been recommending as what we should keep as the reserve options and what should be the general access, the generally accessible, the access category or the watch. Now, just talking a bit about the limitation that we had, or maybe I think we still have here, is that there's this required synergy between two fields, so those doing research on AMR and those in PV. There are fields which are not yet synergizing quite well. And of course, there's the suspicion character of reported events. If someone reports that there is pathogen resistance, it's generally a suspicion, not a confirmed case. So this gives it a limitation, but at least at the level of suspicion, it's also an important information. And then the skills and the capacity gap between those experienced in reporting and those not experienced in reporting, those with better infrastructure and those with limited infrastructure, whether it's capacity on PV reporting or lab capacity to detect, to confirm the suspicion of resistance. And we thought of mentioning this as an opportunity to innovate, because if we think that our step is a first towards the future implementation of surveillance of AMR using PV capabilities, as to provide key elements that can serve as important variables in an AMR causal link assessment algorithm. So those who are innovating, we think that these 17 PTs can be used to develop something which can be adapted at country level or hospital level or regional level. And the basis for this, the exploitation of our results, before I go to the last slide, is that these reports of AMR-related reactions are available in PV database, this we've seen. And there is more relevance for resource-limited countries that maybe have limited capacity to do lab confirmation, and addressing capacity of PV systems using them to collect. So if we think we want to boost PV capacity in different countries, we can use this AMR crisis as something that we all have to address and sell these systems. Mention that if we develop them, we'll be able to tackle many issues, including AMR. Now, one thing that I should mention is also the possibility not only of triggering signals on resistance, growing resistance, but also being able to collect geotagged real-time data. This is something that maybe some of our colleagues doing programming can think of. If you implement such a tool where you can be able to real-time inform maybe those the PV centers where the issue is coming from. If there are big countries that maybe province by province you have to look at spreading your lab capacity in the whole country. But if you have these tools, probably you can generate signals quicker and centralize them in real time. Now, I think that was my last slide. I will thank you and stop there. Thank you.
Thank you very much, Dr. Jean-Marie, for that fantastic presentation as well that shares the intersection between AMR and pharmacovigilance. I think that is also an area that certainly plays a key role in the work that we do, particularly with the growing concerns about antimicrobial resistance. So thank you both for those wonderful and very timely presentations that are apt for the current conversations that are happening, especially in the area of pharmacovigilance. And so with that, I think we can open up the session for questions and discussions. I just want to check with Connie, Fabian, do we have any questions from anywhere?
Okay, we are checking. We will let you know.
All right. All right. So while we wait to see if we have questions from our audience, I do have a number of questions for both speakers, and I'll probably start with the first speaker, Dr. Connie. My apologies if I'm calling you by your first name. It's a lot easier for me. Sorry, not Connie, Dr. Horrell. I was referring to you. So I do have a number of questions from your presentation while we wait to get additional questions. So the first question I had, and that was going through my mind as you were speaking, is what determines how do you determine what drug gene pair, I think you called it drug gene pair, is actionable? How is that determination made? How did you come about, what are the pairs that are actionable? I know you kept talking about actionable gene pairs and the ones that you're working on and, doing, using to do some of the work that you were doing.
Thanks, Cuthbert, and you're welcome. Please call me Tracy, it's no problem. So the information that we're pulling is information that's mostly put together by consortia, so like the CPIC or the Dutch Pharmacogenetics Working Group. So things that have actionable guidelines for drug gene pairs. So we know that the African genetic variants can be very different from those in the rest of the world. So things like tacrolimus have very poor efficacy during transplant because of those differences in genetics. So we're utilizing guidelines that are already in existence to try and implement. It's not something that we're actively going out to source, but we also have our potential drugs that are of interest that we're monitoring how close they are in terms of levels of evidence to see if that's something that we need to start working on.
Awesome. Sounds good. Thank you for that. And then Dr. Jean-Marie, I have a couple of questions for you as well while I wait to hear back from the team. In the work that you shared around the antibiotics that were reported mostly around the AWARE classification medications, and I think you had like 54% or thereabouts coming from those antibiotics in the watch group. I was wondering, would you have a hypothesis for why that is happening, why we're seeing that kind of high numbers?
Yeah, thanks a lot for the question. So that particular slide was related to the data collected from the Dutch database from the Netherlands.
Okay.
And I believe it's one of the countries, as far as I know, which probably has a good control over what is close to appropriate use of antibiotics. So there is not much being taken from the pharmacy without prescription, and maybe it's a place where there's a good balance between what I'd call leaving the reserve on the side, and as much as possible going into the access category. And that watch category, which in the middle, the 54% probably represents what is there as the majority of products used. Looking at, I didn't go into details of each product, each drug, but it's a country which for sure has shown that the reserve is left alone. Maybe the good message from that particular database is the reserve is with 19%, I believe. Whilst I'm afraid if you go to countries where there's not much, where you can get a lot without prescription, you can easily hit a lot of percentages on that reserve category, which would like to protect. So I'm not sure why there's a huge difference between access and watch, but that may be related to the kind of infections that maybe are prevalent in the particular country that we studied. But probably there the good news is the leaving alone of the reserve category, which could be problematic if they are high.
Indeed. Thank you very much for that. Actually, when I saw that, my first impression was that data was actually coming out of Africa, because that was kind of what I would expect given our weaker controls with enforcing prescription based access to medicines. So now that you say it's even from the Netherlands, that gets me thinking some more about really, it gives a different context to my interpretation of that data. But thank you very much for sharing that.
Thanks a lot.
And then I'll come back to Dr. Harrell. A few more questions for you as well. So I think in the beginning, you mentioned the underrepresentation of Africa, of course, in the, is it a gene pool or whatever? I don't know what's the most appropriate term, but there is an underrepresentation of Africa there. And I was just thinking to myself, given where ISoP, given, the conversations that we're doing with pharmacovigilantes working in Africa, is there anything we can do on our part to enhance, that representation? What can we do? What can we all realistically do, if anything?
I think when it comes to genomes and the representation of African genomes, there are a lot of people doing a lot of good work on the continent to sequence genomes and to make sure that data is publicly accessible so that it can be used as a resource. When it comes to preclinical models, we're very often stuck in a situation where the background genetics are typically Caucasian. Or European ancestry. So, and that's a lot of the cell lines, which have been fundamental in Nobel Prizes and changing the landscape of biomedical research, but they don't have the background genetics that are reflective. So we need to change the landscape all the way through. So in the absence of large clinical trials, we do need to have some preclinical models that represent that diversity. So the teams that, like the African Liver Tissue Biorepository, are starting to build these resources. And it's about starting and then disseminating, I think, and making sure that we have skills capacitation on the continent. There aren't many people that work in a lot of these spaces. So induced pluripotent stem cells, there are only a few countries on the continent that have access, as well as the skills. So it's really about skills capacitation and knowledge dissemination at the forefront.
Okay. So given that today we're all about patients, we're all about getting patients more involved in healthcare delivery and all of that, from a patient perspective or from a consumer perspective, there is really nothing we can do in this event. I mean, I suppose what I'm also thinking, and forgive me if this is simplifying the matter, but that just shows my ignorance as well. But, when I think of, those gene pools, I'm thinking like we do blood donations. Is there anything like giving gene samples for, for genes and all of that to grow that the pool or the bank or whatever information pool that is necessary to build the data that we need for Africa?
I think so. When it comes to patient or led research, there are a lot of opportunities. There's a lot of people that are looking at understanding disease so that we can better understand patients at an integrated level. So understanding the genome and the transcriptome so we can better build models of disease. When it comes to patient samples, that's kind of the holy grail of biomedical research. So the more access we have to patient samples, and preferably the less invasive, the better. So blood is a perfect example. If you can understand, you can use blood to understand someone's genome. You can use blood to make induced pluripotent stem cells. You can also use blood to understand someone's disease profile. So those tissues become very, very important to us understanding disease in the context of the continent. And we have to build an understanding of patients not being scared to contribute to research and understanding that their contribution might not impact them directly, but it might impact their children and it might impact their grandchildren because we understand things better. So I think engaging patients into contributing to whatever studies are at their disposal starts building our resources in the most positive way possible.
Right. Thank you. Thank you very much for that. So Connie, just checking back, do we have any questions? I'm not monopolizing the questions. If there are no questions, I can. Okay. All right. While we wait for our audience to ask questions, I will ask a couple more questions and then probably wrap it up. Dr. Jean-Marie, I want to come back to you for a bit. And I wanted to, when you started your presentation, you talked about a toolkit that will help in the work that we do in pharmacovigilance and AMR. And I might have missed this, but in your work, have you kind of put together like a toolkit or a guidance, something that people who work in pharmacovigilance or AMR can, use to start thinking about? I mean, some of the things you shared were quite eye-opening for me in terms of thinking about some of those reactions that could possibly be related to AMR. That was certainly something that wasn't actively going on in my head, but when you mentioned it. So do you have, those kinds of guidance that will help people like me start thinking around that? If you have a guidance or document or something, I see you have a lot of publications, but have they all been brought together in a sort of toolkit kind of way that we can take away and use?
So I think the truth is, by the time I finished those studies, I was very active, engaged, discussing friends and colleagues and professionals in different fields to see if a tool can be developed. What I was mentioning in that slide about exploiting those results. So my idea was really to use the most important findings in my studies was that list of 17 PTs. So those were the basis for me to propose to say, if there is anyone who is good at developing apps, or if there is a PV app which is already there functioning and it can get another additional feature which uses those particular 17 PTs to see if we can have a sub database which systematically collects ADR reports based on those 17. So I was at a stage of discussing, but right now, after publication, it is in my world, it is the most open access thing that I say, please go ahead. Anyone who wants to develop it, I'll be happy to help. I published those papers and I produced a podcast where I also invited those who maybe the listeners of that podcast to come in with extra ideas if there's something that I missed. So myself, I did not develop it. I stopped at the stage of shortlisting those PTs and giving avenues where I proposed an app kind of tool, which would maybe be the center of the reporters, being, for example, the hospital, the pharmacist, and those would come collect and collate and interpret the data, which in this case would be focusing on that AMR aspect, which would still have the character of suspicion before anyone confirms, but the idea being that if there is a signal that can be expressed in terms of peak number of reports on a specific antibiotic or in a specific PT, then those would be the signals that maybe governments or hospitals can act on. But the tool in answering your question was, in my idea, it is an app or a website, but I did not enter into the step of making it myself.
Thank you very much for sharing that. That's appreciated. And just to check with the two presenters, there's obviously a lot of interest from people to get to the presentation. Will you be sharing your presentations with us? I'm sure we'll follow up with you on that, but just to note that there is an interest in getting that, and we'll be happy if you're able to share at least those parts of your presentations that you feel comfortable to share with us. Our members would be very delighted to have them. So we have a question about the work, how other regions that probably have similar issues in terms of representation of the genomes in the global research, how those regions can reference or use part of the work that you've done, Dr. Hurrell. How can other regions use that to support, the work that they also doing?
So there are a couple of groups that are trying to expand into various regions across the continent. So when it comes to genome studies, there's a lot of work being done across the continent in terms of with collaborators both in South Africa as well as in Europe and America. When it comes to accessing preclinical models, there's a lot being done in South Africa and Zimbabwe, but further up in Africa, there seems to be somewhat less. But some of our team is working with skills capacitation with certain regions that are potentially interested in setting up some of this work. The issue we tend to find is that a lot of it is quite expensive. So to run these models in your laboratory, it does take a large cost. So setting up these labs does tend to require a lot of startup costs, but there are opportunities to reach out to myself as well as the group that I work in to see if people are interested in collaborating on projects and ensuring that we kind of expand this genetic diversity within these preclinical models.
Thank you. I imagine that your interests would go beyond Africa. It might be starting in Africa, but certainly expanding it to other regions as well. So
Absolutely.
thank you.
Absolutely. I think everyone in an ideal world would be well represented. It's just about a lot of the conversations we have in Africa, where do we start? And we know we have to start. So as long as we are starting and we are getting momentum, we can have grand visions and know that we'll get there.
Absolutely. Thank you for that. And while I have you, I have a question for you that that's coming also that we want to check with you. Again, just referencing why we're here today is about patient safety. We're celebrating the Patient Safety Day and all. And the question is, how can the work that you're doing in genomics support or enhance patient diagnosis, given the theme of the Patient Safety Day for this year? How can it support better diagnosis for patients?
Thank you for that question. So some of the work that we do here I have not alluded to in this presentation, but we in our lab work also on single cell transcriptomics and using patient-derived cohorts to better understand disease at a single cell resolution. And that in an ideal world is the real root of understanding both diagnostics and therapeutics. So the more we can understand diseases that affect the population at a single cell level, the more we can understand how to better diagnose and then how to build better therapeutics. So a lot of this work is also very much in its infancy on the continent. There are very few labs that have access to single cell technologies, but building on that kind of work, we are setting up some work in the liver space around that. So better understanding disease at a single cell level will help us better implement diagnostics, hopefully. But those horizons are, unfortunately, they are long. We first need to capacitate and then build those data sets that help us.
Fantastic. Or at least they say the journey of 1,000 miles begins with a step. So we're very happy to see that the beginning steps are already in place, and your work is really laying the foundations for those 1,000 miles that are still in the future. And so just a last check from our audience. I don't see any additional questions. And I just want to pause a moment to see if anyone has a thought or anything they want to share. And the presenters are also welcome to share any questions they have for the other presenters. So I just wanted to check if Dr. Hurrell, if you have any questions for the AMR presentation, and vice versa, Dr. Jean-Marie, if you have any questions for the other presenter. Not to put you on the spot, of course. And if I'm happy to.
I actually have a question for Tracy, because I often look at these things from a finances perspective. Countries have limited resources, then they want to embark on these great solutions. And I know, for example, pharmacovigilance is not a course which is offered in many medical schools. You start doing it when you're already qualified in something. I wonder if Tracy sees a problem in resource limited countries where you have maybe 1 or 2 universities per country, and maybe the ministries of education are trying to do their best to offer the best curricula to the students. Is this field something which may be missing because financing is a limiting factor, because in some countries we don't have capacity to invite experts who can train people in what you are doing?
Absolutely. I think there's always a need to look back at how people are being trained, and then seeing if we want to implement all of these grand ideals, where do we start teaching? Where does it filter from? Is it that we go to the university level and we start teaching there? And those kind of groups build into the public healthcare space, or do we have to start in the public healthcare space now? It really is a difficult position to try and understand where do we accelerate the impact. So a lot of the information that we're getting is that pharmacist level is a potential opportunity where we are skilling pharmacists in understanding. But we also sit in a position where a lot of people, they don't get the granular information at the school level. I got a lot of my expertise overseas. So where is our responsibility then as well to come in and understand where the gaps are and then disseminate? So yeah, I think education is our limiting factor to implementation, because a lot of people also, we have access to some PGX screens. I can go and pay for one now, but how does my doctor know how to implement it for me? How does my pharmacist know how to implement it? That kind of information has to bridge the gaps before we start actualizing anything. And I think for every country, it's going to be slightly different on how to actualize it. We can't have these kind of Pan-Africa ideals. It has to be what works in my setting, what works in my local setting. It can be a radius of 10 kilometers. And that makes it also scary in a different way. How do I make sure that I capacitate people to ensure that patients are still safe?
Yeah.
Fantastic. Thank you for that. Okay. We have another question from the audience, and Dr. Jean-Marie, I believe this is for you. So it says AMR is a global problem, and much of this is because of pharmacy dispensing antibiotics without prescription. Any particular strategy for combating that?
Yeah, I think the particular strategy is to learn from countries that are maybe championing this idea of just hiding as far as possible the reserve category of the aware classification. But you do that only if the legislation is coming along. So if you have a country that enforces the prescription and make sure also the prescribers do not start looking quickly at the reserve list or the watch list. So a legislation which really provides, it sort of encourages the prescribers to just focus on the access. If needed, they go to the watch. If needed, they go to the reserve. But at pharmacy level, you really depend on those two. You depend on the legislators, Ministry of Health, going to the politicians, raising awareness about this issue, and then making sure the prescribers are given rules to follow. Because the pharmacist, if there is no law that says do not give daptomycin, if you see no prescription, the pharmacist will give daptomycin. So you need the politics and the prescribers. So there are countries that seem to be doing well. One of them is maybe the Netherlands, if I look at Europe, for instance. So at PV national levels, I know there are programs that collaborate from country to country, and it is there where maybe the PV national groups can maybe seek guidance from those that are maybe doing better and start influencing the policies in their own countries.
Yeah, thank you. Thank you for sharing that thought. And I remember when I was studying my work as a regulator, one of the key terms I heard back then that kind of stuck with me, I think this was something from WHO, when we used to talk about dispensing doctors and prescribing pharmacists. So as being part of the problems that we tended to have in healthcare delivery. But I think also as things have grown over the years, we're getting to the point, just, picking up on your point about the policies and the legislation in place, we're getting to the point that we do recognize the overburdened healthcare providers, and they need to really take a very good look at the task shifting strategy, where we can empower those healthcare providers, for instance, pharmacists, who can provide some level of services, that can also support our ability to monitor these medicines and reduce the prescription access without prescription. Given the level of education that the pharmacists already have, I think it's a good idea for countries to start looking at how do we capacitate them more legislatively, to be able to provide some of that support. So there is a question for, this is for you, Dr. Hurrell. It's pharmacogenomics is expensive. How can we institutionalize it in Africa?
Thanks, Humpert. So as we start developing more and more technologies, a lot of array-based technologies, it does become cheaper and cheaper. So there are a lot of, like, I will speak in the context of South Africa, and I'm not sure about the rest of the continent, but within South Africa, we have already got about 4 or 5 service providers that do various PGX arrays of different sizes. So from a 60 array panel to 120 array panel, and you can get a 120 array panel for about, I think it's about $170. So we are hoping that these things become cheaper and cheaper, but that's also why when we are contextualizing specific prescriptions, if we look at tacrolimus as an example, a dose of tacrolimus is sometimes more expensive than your PGX panel. But if I do my PGX panel, I know how to effectively treat that patient. So when it comes to the implementation, we have to then start thinking, what are my biggest drugs that are issue within the population, and how is that impacting them? And then which are my most vulnerable population groups? So it might not be easy for us to go and do PGX for codeine and tramadol, where people are, we're mass amounts of prescriptions on a regular basis. But if we're looking at something like tamoxifen, where we have a CYP2D6*17 allele that makes the drug essentially ineffective, that population cohort is a lot smaller than people that are on analgesics. So how do we then, within each country, within each setting, start thinking, what is my need? Do I want to prioritize tamoxifen and tacrolimus and reach that patient cohort? And then as things start becoming cheaper, we start expanding them to other drugs. And that's really why we've gone around the ADRs and the pharmacoeconomics, as well as the number of prescriptions. And that is a caveat in some of the work we've done. We have numbers of prescriptions and not numbers of patients. So that can be slightly offset when it comes to repeat prescriptions. But it's really how we are trying to think about it. Where do I start? Where's the priority? And then making sure that we have access to those things in the future.
Indeed. Thank you so much. Where do we start? What are the priorities? Where are our priorities? So those are some of the questions that we need to respond to. We need to think about, we need to go with as we continue to celebrate today's Patient Safety Day, as we continue to think of how we're going to make our patients safer, as we're going to improve their diagnosis, their treatment, as well as post-treatment effects of the medications that we give to them. And so with that last word and no additional questions from our audience, I will bring this session to a close by saying thank you to all of you, to our speakers, for your valuable time and contribution to making this Patient Safety Day event possible. We have been blessed and enlightened by your presentations, and we're leaving much better than we came, much better informed than we came. And so with that, I will ask our audience and everybody, please join us for our upcoming presentation. The next Patient Safety Day session will be that of the European region, and it will begin in, I think, about 5 hours or 2 hours. We encourage you to visit our ISoP Online Facebook page or our YouTube channel to view this webinar and all the other webinars for the day. And then we will publish the records from this event in the next few days. It will be on our online, on our website, on the ISoP website. And on behalf of ISoP, just want to thank everybody for your participation. Want to thank you for your time. Want to thank the presenters for being with us and the organizers for taking the time to organize today's session. So on that note, I say thank you all and enjoy the rest of your day. Bye.
Thank you very much.
Hello, I am Angela Caro. I am the president of the International Society of Pharmacovigilance, ISoP. And ISoP is a society of pharmacovigilance who works in how to improve medication safety in the world. We have presence in more than 100 countries, and we are very proud about what we are doing and the society. We have more than 14 chapters. It includes chapters of Africa, China, and North America, Latin America, and other regions. And we are organized by special interest groups too. We have some groups like We Are World Evidence, like medication errors and herbal and traditional medicines, and risk communication, and other groups. We have some meetings that are the perfect excuse for meeting with some people that work in the same field that we work. For example, we have the mid-year symposium each year, and we have the biggest event in pharmacovigilance in the year in the world is the annual meeting. In the annual meeting, we have some conversations with experts who work in pharmacovigilance in different topics. We have sessions for each SIG, and we have the possibility to present some abstracts and oral presentations. We have events with more than 400 posters, and it is so useful for people to show his work. I think that being a member of ISoP is so important because you could build knowledge and you could share with partners about the topic that you are working in pharmacovigilance, and it helps a lot of people. It helps the patients, it helps the communities. We work with regulatory agencies, we work with WHO, we work with other people who is involved in education safety. Then please join us, see more about us, go to our webpage, and for sure we will find something for working together. I am the president of
Good morning, good afternoon, good evening, everybody. I know that many people are connected from different parts of the world, so it's a pleasure to be here. On behalf of the International Society of Pharmacovigilance, ISoP, we are very pleased to welcome all of you to this, the 5th edition of the ISoP Patient Safety Day event that will be held in the next couple of days from September 12th to September 13th. Let me introduce a little bit myself. My name is Felipe Villalobos. I'm a medical doctor with a master's degree and PhD in public health. Currently, I'm working as a primary care researcher at the IDIAP Jordi Gol, which is the Primary Care Research Institute in Barcelona, Spain. Also, I'm a lecturer in the Faculty of Health Science by the Universidad Oberta of Catalunya, and a member of the European Health Parliament in the Wellbeing for Healthcare Professionals Committee, and I'm co-coordinator of the ISoP European chapter. I'm delighted and super happy to be the moderator of this event for the European region. So the main reason that we are here is the Patient Safety Day, but what is the Patient Safety Day? I will just mention some information about what is the Patient Safety Day, why are we doing this? So the World Health Organization established a dedicated Patient Safety Day to increase public engagement in healthcare safety and promote global actions to prevent and reduce avoidable harm in healthcare. This year, the World Health Organization is promoting improving diagnosis for patient safety. So that's why, that's what one of the reasons that the ISoP took care of this message, and ISoP reaffirms the objective of the World Health Organization Global Patient Safety Day Challenge and calls on stakeholders and health professionals to prioritize and take early actions in critical areas associated with significant patient harm due to unsafe medication process, for example. These include high-risk situations, transition of care, polypharmacy, and other serious disruption in the provision of health services. So let's start this event with a short message from the president of the International Society of Pharmacovigilance, Angela Caro. Please listen to her because she will dedicate a few words from all of us that are in this event. So please, can you help me?
Hello, I am Angela Caro. I am the president of the International Society of Pharmacovigilance, ISoP. And ISoP is a society of pharmacovigilance who works in how to improve the medication safety in the world. We have presence in more than 100 countries, and we are very proud about what we are doing and the society. We have more than 14 chapters. It includes chapters of Africa, China, and North America, Latin America, and other regions. And we are organized by special interest groups too. We have some groups like We Are World Evidence, like medication errors and herbal and traditional medicines, and risk communication, and other groups. We have some meetings that are the perfect excuse for meeting with some people that work in the same field that we work. For example, we have the mid-year symposium each year, and we have the biggest event in pharmacovigilance in the year in the world is the annual meeting. In the annual meeting, we have some conversations with experts who work in pharmacovigilance in different topics. We have sessions for each SIG, and we have the possibility to present some abstracts and oral presentations. We have events with more than 400 posters, and it is so useful for people to show his work. I think that being a member of ISoP is so important because you could build knowledge and you could share with partners about the topic that you are working in pharmacovigilance, and it helps a lot of people. It helps the patients, it helps the communities. We work with regulatory agencies, we work with WHO, we work with other people who is involved in medication safety. Then Please join us, see more about us, go to our webpage, and for sure we will find something for working together.
Thank you so much for all your attention. A few words from the president of the ISoP, Angela Caro. We would like to encourage you to share your experience at this event using some hashtag listed, for example, hashtag ISoP Online PSD 2024, hashtag ISoP Medication Safety, hashtag ISoP Med Air, hashtag ISoP Medication Without Harm, and hashtag World Patient Safety Day. Please, we encourage to share your thoughts about this event, about the topic. Also, you can publish some pictures and ideas about the patient engagement. Okay, before to start, I will introduce our first speaker. It's an honor for me to have Dr. Albert Figueras. He will present his conference entitled "How Can Pharmacovigilance Become an Active Player to Tackle Antimicrobial Misuse and Resistance?" Dr. Albert Figueras is a medical doctor and clinical pharmacologist. After working for the Spanish system of pharmacovigilance, he has been a consultant on medicine safety and pharmacovigilance strategy to support the development and strengthening of pharmacovigilance in more than 50 countries in Latin America, Africa, and Asia. Part of his work has been focused on the support of the smart use of medicine at different levels, and he is currently promoting the interaction between pharmacovigilance and drug utilization, including the use of antimicrobials and the containment of resistance. He has been a scientific advisor of AMVISA in Brazil. He is actually a retired professor of pharmacology at the Universidad Autónoma de Barcelona and UTP, Universidad de Bordeaux. At present, he is an independent consultant working in different projects for the World Health Organization, for the Pan American Health Organization, the World Bank, the Asian Development Bank, and Africa CDC. So please, Dr. Albert Figueras, just a small reminder, we invite you to all the participants in this section to be active. So if you have any question, please put them in the chat box. We will respond to some of them as our schedule permits, of course, and the rest will be collected, and then question and answer list will be published on the webpage, isoponline.org. So without saying something else, we welcome Dr. Albert Figueras. Please, the floor is yours. Thank you so much.
Thank you very much, Felipe. I will share my screen. Here we go. So, well, as I said, thank you, Felipe, and thank you also, Hager, Brian, and ISoP team for inviting me in this Patient Safety Day. First of all, let me go to the next screen. No. First of all, let me talk about the conflicts of interest. I think it's important to disclose that I have no contract or I have not received any funding from any manufacturer. I think this is important because as we are dealing with medicines, it's interesting to be clear. But as interesting as the funding, the economic aspect of life, I think it's important also to disclose the conflicts of perspective. And this is why I think it's interesting that you know that I am a medical doctor and clinical pharmacologist. I am not a pharmacist, but I am not a medical doctor directly interacting with patients. However, my background, I think that helps me provide a different perspective, a different point of view. And as Felipe said, I am interested in the smart and safe use of medicines. It is also interesting to highlight that I was born and I live in Barcelona. However, I have been working with healthcare professionals, with healthcare authorities, and also with populations in many countries. So my point of view is, or I tried that my point of view is not a north-south point of view, but more south-south or south-north point of view. And it's interesting to disclose this perspective in order to understand some of the things that I will be proposing. And last but not least, I am interested in René Magritte. René Magritte, as you probably know, was a Belgian painter, a Belgian surrealist painter, and one of his most famous works was this one. This one, it depicts one pipe, and it says, written in hand, "Ceci n'est pas une pipe." This is not a pipe. Of course, when you read this for the first time, you think, okay, surrealist paintings were like this, and you never know. Their message sometimes sound crazy, etc. But if you think it twice, really you realize that the message is true, because this is not a pipe. This is a painting of a pipe. You can't hold this pipe and smoke with this because it's not a pipe, it's a painting, okay? And I think that this is interesting, related to what we are talking about today. We are talking about pharmacovigilance, and I realize that, I don't know, 97% of advertisements, 97% of logos, of web pages related with pharmacovigilance, they include images such as this one. Tablets, capsules, vials, syrups, etc. But to me, this is not pharmacovigilance. And this is also a conflict of perspective. I mean, to me, pharmacovigilance is not about medicines. Pharmacovigilance is about patients, people that take a medicine and the effects that these medicines produce on these patients. So the perspective of patients is very important, in my opinion. And in fact, I really don't understand a lot that dissociation between pharmacovigilance and patient safety, because to me, pharmacovigilance is patient safety. If we ensure safety of patients, we are trying to use the medicines in the best possible way that we know. So if we look at the web page, WHO web page, where they talk about patient safety, they say, okay, common sources of patient harm are medication errors, surgical errors, healthcare-associated infections, etc. And I used to ask myself, okay, but what about the inappropriate or irrational prescriptions that one day after another are common practice everywhere? And some of these inappropriate and irrational prescriptions end with a damage, a harm for patients. What about not avoiding prescribing and over-prescribing certain medicines in the elderly population, for example? What about the prescription, etc., etc.? So in my opinion, pharmacovigilance should be wider than the classical let's say, description of pharmacovigilance to include, to focus on patient safety as something broad. And in my opinion, this could help strengthening pharmacovigilance system, national pharmacovigilance programs, and could be the occasion to start promoting reporting for prescription-related problems. And these include therapeutic failure, and these include, for example, suspected antimicrobial resistance. And here we go. This is the title that I suggested Hager when she invited me for this session. How can pharmacovigilance become an active player in the containment, or to try to help the containment of antimicrobial resistance? And as you probably know, antimicrobial resistance is really a problem nowadays. In fact, since many years ago, really since a couple of years after penicillin was started its use, resistance has been described as a problem. However, in 2016, the General Assembly of the United Nations decided to focus on one problem related to health. In fact, the General Assembly had considered healthcare or health-related problems 3 or 4 times before 2016. And the previous one had been HIV and that crisis of antiretrovirals, access to antiretrovirals in the early 2000s, okay? So in 2016, they decided to focus on antimicrobial resistance. It was in May this year that WHO, also the General Assembly, pointed to the public health importance of antimicrobial resistance. We have a problem in front of us. It's a growing problem, so we need to act in order to I don't know if stopping, but at least trying to contain as much as possible antimicrobial resistance. And in fact, in a couple of weeks, the new meeting of the General Assembly of the United Nations in New York will focus again on antimicrobial resistance, meaning that it is a huge problem, a huge public health problem that we have in front of us. And really, if you look at the light green part of this diagram, you will see the most common causes of death today in the world. Okay, so it has been calculated that more or less in 1 year, 10 million people die from cancer, 1.5 million people die because of diabetes or complications of diabetes. 1.4 million people, at least, die from diarrheal diseases. And it was calculated in 2022 that approximately 1.2 million people died as a consequence of antimicrobial resistance. And it's important to keep in mind that this means that, yes, these people died, but there are many, many other people with morbidity, long hospital stays because of resistant infections, etc., etc. But the point is that it has been calculated that in 2015, this means in 25 years, there will be 10 million deaths, 10 million fatalities per year because of antimicrobial resistance. So we have a huge problem, and it's not an easy problem to solve because, as you know, the number of new antimicrobials, unfortunately, is quite low. And even when a new antimicrobial is marketed, soon after the authorization, new resistance start to appear. So it's a quite difficult problem to address. Let me remind a couple of details about resistance. You all know that there are bacteria that are sensitive to certain antibiotics, and there are some strains of the same bacteria that are resistant. If you look at the first circle that appears in the left, you will see a different green bacteria. These are sensitive, for example, to amoxicillin, and one red bacteria, which is resistant to amoxicillin, okay? When we prescribe amoxicillin to that patient with an infection with this bacteria, the green ones will be killed, so they will become the gray bacteria in the second circle, and of course the red one will survive, and not only will survive, but will continue to divide, and you will see this in the third circle. A lot of resistant bacteria that continue maintaining the infection. So we have given amoxicillin to the patient. It seemed that the patient healed, but in the end, the infection reappeared, and amoxicillin was useless at this point. So we need another antibiotic. We need a second line, third line antibiotic, and certain situations, a last resort antibiotic in order to be able to heal this patient. What is interesting here, and this is something that we have learned quite recently, let's say, is that first, bacteria can transfer drug resistance to other bacteria, not only by dividing themselves, and then spreading the material, the genetic material to, let's say, their daughters or their offspring, but transferring to another bacteria this genetic material, either plasmids or genetic material that is exposed, for example, to sewage, to wastewater, to fresh water, etc., etc. So there are a lot of studies that show that in certain parts of the world, water contains these particles with genetic material that confer resistance, and this material is, let's say, captured by other bacteria. So this is, on the one hand, interesting to know, but on the other hand, this is extremely worrying because it highlights the importance of a concept that was given in 2015, that is the One Health concept. We are not walking alone as a species in the case of antimicrobial resistance. Antimicrobials are being used in farms, are being used in humans, and the environment helps to connect all these different participants, let's say, or involved living beings. Now, let's see how we can know which antibiotics can be used in a patient with certain infection. You already know this, but it's interesting for the explanation that I will say after that to keep in mind this diagnostic aspect. In order to know if certain bacteria, certain strain is sensitive or resistant to antibiotics, we need to take a sample and culture this sample. You can see in this Petri plate, you can see how bacteria grows. Then we put on these plates, we put these white circles, which contain different antibiotics. For example, amoxicillin, cefuroxime, azithromycin, whatever, okay? When we place these white discs on the plate, then if the bacteria is sensitive to these antibiotics, we can see that gray halo. That means that bacteria doesn't grow besides this disc containing a specific antimicrobial. In this case, in the example that you see here, bacteria are sensitive to all four antibiotics that have been tested. However, in certain cases, the situation is quite desperate. For example, you can see here that only one disc containing one antibiotic is able to stop the growth of the bacteria that are growing in this Petri plate. However, some of these discs don't have any effect on these bacteria. This means these bacteria are resistant to these 2, 3, 4 antibiotics and are slightly sensitive to the ones with the smallest halo. So, to be able to know the pattern of sensitivity or the pattern of resistance of bacteria, we need a laboratory, we need a specific material, we need these discs, we need, of course, trained personnel. And unfortunately, this is not available everywhere, every time. Let me show this map. This is an example of the global antibiotic resistance, in this case for Klebsiella pneumonia, one quite common bacteria. You can see in this map different colors. Different colors show the resistance score based on samples taken in these countries. However, I am interested not in the colors, but in the gray parts. And you will see that there are many countries without any data about resistance in the case of these bacteria. And this is exactly the point where our worries start. How is it possible to try to bridge this gap? Of course, we could think in solutions, trying to train hundreds of healthcare professionals, trying to put in place hundreds or thousands of laboratories with material, etc., etc. But this takes time, and this is not as easy as it can seem, in addition to be very expensive. So the idea is, okay, we have a problem with resistance. Resistance doesn't know about borders. I mean, one person can be in Namibia, that is one of the countries painted in gray, and that patient can fly and come to the United States, come to France, come to India in 10 hours. And if that person brings a resistant strain, that resistant strain rapidly starts growing in the other part of the world, so that the concept of border obviously doesn't exist for bacteria, for resistant bacteria. And also resistant bacteria, we know that they, let's say, travel using other ways, for example, rivers, for example, sewage, etc., etc. So we need to have a solution in order to try to improve the safety of patients all over the world concerning antimicrobial resistance and the effects of this resistance. Then the point is, could we use the suspicion? I mean, laboratory, of course, will provide certainties, will provide evidence. But the point here is, okay, we know this, but now let's try to think outside the box. And outside the box, we that work in pharmacovigilance and patient safety, we are very used to work with suspicion because, in fact, reports are suspicions about symptomatology that perhaps is associated with a medicine. So our daily work is to suspect and to deal with suspicion, with algorithms and all these things. So could we use suspicion related with antimicrobial resistance? Could we identify through suspicions clusters of patients that are resistant to a specific antibiotic, for example? And in addition to this, could we report these cases, these suspicions? So at some point, Gianmaria Barrigira took some previous ideas studied or published by WHO, and he said, okay, let's analyze this possibility. And to do this, he conducted a deep analysis of the MEDRA dictionary, and he also analyzed what has been reported in the BG base. And he identified 17, at least 17 MEDRA terms that could describe something more or less related or that could suggest resistance. For example, drug ineffective, pathogen resistance, treatment failure. These are actual MEDRA terms. These terms are in the dictionary that we use every day. So the point is, could we at some point use these terms that already exist to try to point, to try to report suspicions about resistance, especially in places where we don't have a laboratory, a reference laboratory where to send our samples and to obtain results more or less immediately in order to be able to treat patients. But at least could we alert on our suspicion in order to do something with this suspicion? So Jean-Marie grouped these terms. He found these 17 terms and he grouped them as resistance, suggesting ineffectivity, suggesting off-label use. That is another indirect way of thinking about the use of antimicrobials that eventually could lead to resistance, and medication errors and drug prescribing errors that also could put on the track of potential of label use, irrational use, not justified use, and eventually resistance. And he found that there were, on that time, more than 50,000 reports of adverse drug events in database describing using these 17 terms, and these reactions only for the group J01. This means antimicrobials, anti-infectives. So it seems that it is possible to do something, to report something related to our problem in this case, that is antimicrobial resistance. In addition, together with Linda Hallmark from the Netherlands Pharmacovigilance Center, they decided to analyze what happened in a pharmacovigilance center, international pharmacovigilance center that is mature, as is the Netherlands Pharmacovigilance Center, and also in a country that typically is considered a country with good records regarding the use of antimicrobials. So they decided to look at the national database of the Netherlands Pharmacovigilance Center in order to try to identify reports that already were in the database. And of course, they found that there are reports describing, without any intervention, spontaneously, the database already has reports suggesting antimicrobial resistance, suggesting non-use related issues, for example, off-label use of antimicrobials, etc. And they found, in this case, 252 reports in this database. And it's interesting to know when we look at the involved antimicrobials that a number of reports involve watch antimicrobials. This means second-line antimicrobials, those antimicrobials such as macrolides, cephalosporins, fluoroquinolones that we tend to reserve for cases that really require these medicines, and also surprisingly, some reserve antibiotics. 45 reports describe some reactions of label use, drug ineffectiveness associated to reserve antibiotics that really are those that are considered last resort. So, according to these studies, we have the terminology, and pharmacovigilance seems that naturally collect these reports. Of course, the number spontaneously collected is quite low, but this is the point. We have the tool, so perhaps it could be possible to propose more actively to use these terms to report resistance, which will be especially interesting in certain places where antibiotics are not close to the place where patients live. In addition to this, recently, Balsieri Sandes and Elisangela Costa Lima from the University of Rio de Janeiro, Universidade Federal de Rio de Janeiro in Brazil, they conducted a narrative review of all the studies that have been conducted on antimicrobials, and that also collected or analyzed information concerning drug effectiveness or concerning off-label use of medicines, of antibiotics in this case. And of course, they found that there are different studies that are looking at this. So again, we have another confirmation of the feasibility of this suggestion or this proposal. So, in summary, we have, I would say, the largest network linking health authorities, health professionals, and people, which is the pharmacovigilance network. As you know, the Uppsala program, let's say, the program for international drug monitoring, it includes more than 170 countries at present. So each country is like a node, like a hub that connects the other countries with healthcare professionals and eventually with patients, with people. I listened to an officer, a WHO officer in charge of pharmacovigilance, perhaps a couple of weeks ago, and she said, no, the WHO pharmacovigilance program covers more or less 90-something% of the world population. So we have something that in theory is strong, is a strong network. Another thing is what happens with all these nodes, with all national centers, because obviously, as you know, there are some centers that are extremely active, that are mature, etc., and there are other centers that are just starting, that need more funding, etc. But the network is here. In addition to this, we use a tool, which is the MEDRA dictionary, and that dictionary already contains a number of terms that allows us to report this kind of problems without having to add new terms. And this is the good news. We already have this. We have the network and we have the dictionary. And to me, we have another aspect that is difficult to quantify. We have another aspect that is the beautiful aspect of pharmacovigilance and patient safety, if I may say. That is, that in the end, it is a knowledge made by the collective approach, by the collaboration of many, many actors from different parts of the world at different levels that are just interested in reporting something in order to improve our knowledge about medicines and the effects of medicines. And this is why I use this image to illustrate this. For those that don't know, this is a human tower, a human castle. Here in Catalonia, we used to do this type of things in our, let's say, holidays. And the point is that, of course, the persons that are building the tower are very important. However, this tower, without the base, without those people in the base that are pushing to avoid the collapse of the central tower, are also essential. Pharmacovigilance is this. There are certain nodes, certain hubs in this network, but however, the results of the network are the result of the interest, of the participation of many, many actors, many persons. And the point is here, we are complaining of underreporting. Some pharmacovigilance centers say we don't have enough money. The Ministry of Health don't believe in our work. So, okay, let's show that we can do something in addition to what they say, just collect reports of adverse drug reactions or events, okay? And this can be, let's say, an added role, always related with patient safety, always related with the use of medicines, but that can have a consequence, a good consequence, and can be used in another aspect that is not related or strictly related with pharmaceuticals. So can we suspect antimicrobial resistance in certain patients? And can we report this suspicion? In my opinion, yes. And it's something that it has already been done. And in the end, this means that pharmacovigilance centers can win with this approach. They will have a new task, a new activity that can help to overcome underreporting by engaging again potential reporters. People working with infectious diseases, microbiology labs, antimicrobial stewardship, etc., can win with this approach because not everywhere there are laboratories ready to detect, to find the evidence and detect in a timely manner resistance of certain bacteria of interest in the specific patients, etc., etc. So if we have an alert system, which is the pharmacovigilance system, and this pharmacovigilance system talks with people working in microbiology, in infectious disease, etc., in the country, then it's possible to establish a system of alert in case of clusters that can be similar to the concept of signals that we use in pharmacovigilance. And of course, the third winner, the third circle, is for the population. Obviously, patients can benefit if more reactions can be detected. So, in the end, in my opinion, if we try to joint efforts between pharmacovigilance and antimicrobial stewardship, antimicrobial resistance monitoring, we can help to curb antimicrobial resistance and perhaps to improve how antimicrobials are being used. And of course, I would like to thank Gianmaria Barbira, Linda Hammark, Balsiani Sandes, and Lisangela Lima, because they have spent a lot of hours trying to conduct these studies that I have shown. And that's all. Thank you very much. And of course, if you have any question, I will be glad to answer. Thank you very much.
Thank you so much, Dr. Figueras. I think this was a very nice presentation highlighting this topic that, in my opinion, I think is a very public health concern. Regarding the questions and answers, what do you prefer? Do you want to make this round now or after the next presentation? What do you think is the best?
As you prefer, Felipe. For me, it's the same.
Okay, we will take the questions at the end. So maybe some questions can be also answered for Hacker. So I will just introduce our second speaker. I want to apologize because Dr. Brian Edwards will not be attend to this event for personal concerns. But here we have Dr. Hager Saleh, who will present the medication error subgroup for pharmacovigilance and antimicrobial resistance. Dr. Hager Saleh is a PhD candidate in health system and policy at Karolinska Institute in Sweden. Her doctoral research focus on optimizing antibiotic use, digital health, and strengthening pharmacovigilance within health system. Currently, she also works as a pharmacovigilance profession at a leading CRO in Stockholm. Hager has over 8 years of experience in teaching and healthcare management with a strong focus on quality improvement. She previously served as a lecturer in health service managers at UMM Quara University, hope I pronounced very well, in Saudi Arabia, and early worked as a hospital pharmacist in Egypt. She holds a master's degree in health informatics from Karolinska Institute, pharmacovigilance and pharmacoepidemiology from the University of Bordeaux, and hospital admission from Alexandria University. Her research interests include drug utilization, patient safety, and healthcare policy, and she has authored several research articles in this area. So please, Hager, welcome, and the floor is yours.
Thank you, Philip. So I will share my screen. Yeah, so which of you can see it now?
Yes, we can see you.
Presentation view. Yeah.
Yes, it is in presentation view.
Great. Yeah, thank you for your presentation. And following Albert's insightful presentation, I will now introduce AMR subgroup within the medication error special interest group of ISoP. Our focus is on integrating pharmacovigilance to combat antimicrobial resistance. Today, I will share our goals, planned activities, and how we aim to make a significant impact on this critical global health challenge. Yeah, so antimicrobial resistance is a growing global threat, compromising the effectiveness of life-saving treatments. The graphic on the right.
Sorry, Hager. Sorry to interrupt you. There is. Can you change the screens, because we are seeing the wrong screen.
Yeah. So now.
Now, it is okay. Yes. Thank you.
Okay. Great. Yeah, so the graphic on the right highlights that more than 35,000 deaths occur each year in European Union to antibiotic resistance infection, with over 70% of these infections being health care associated. Significant contributors of AMR are medication errors and inappropriate use of antibiotics. That is why the AMR subgroup within the medication error seg was established. Let me first introduce the medication seg. The SEG is chaired by Dr. Brian. Our group is a diverse collection of experts in pharmacovigilance and drug safety from academia, industry, and regulatory authorities worldwide. We meet on monthly basis to discuss topics in medication safety. So also we invite guest speakers. Our meetings provide updates on recent events or updates on different topics on medication errors. Our mission is to create a global network of sharing evidence and solutions to reduce medication error, ultimately ensuring safe use of medicines. To achieve these goals, we actively facilitate research, providing opportunities for networking, We also promote education on medication error and prevention. Our key activities: regular meetings, collaboration, trainings, and targeted subgroup initiatives, such as the AMR subgroup. Our AMR subgroup was initiated following discussions during ISoP annual meeting in Bali last year. From these discussions, we planned and started the planning and formatting early this year. Our mission is to combat antimicrobial resistance through targeting pharmacovigilance effort, education, collaborations, and advocacy. We aim to ensure safe and more effective antibiotic use globally to address this critical health challenge with a comprehensive and proactive approach. Integrated Antimicrobial Resistance Action Program is an initiative of our subgroup. The program is designed to combine education, training, data analysis, and advocacy. We are taking a holistic approach to address AMR challenges by strengthening pharmacovigilance and data-driven insights and strengthening partnership. The most important thing here to mention, the development of this program has been guided by valuable input from experts such as Dr. Albert, whose insights have helped us to ensure our approach is comprehensive and effective. This program mainly the program goals include raising awareness by empowering healthcare professionals, policymakers, and the public with knowledge on AMR. Education and training, like enhanced knowledge in pharmacovigilance, antibiotic stewardship, and the safe use and effective use of antibiotics. Collaboration, we plan for partnership with stakeholders to create unified efforts in AMR, surveillance, and response to AMR. Advocacy, promoting policies that support reasonable antibiotic use and safeguard the public health. Our AMR subgroup has several planned activities to support our mission. We will hold regular virtual meetings to maintain engagement and collaboration. We aim to build partnership with global organizations and experts to strengthen our impact. We will launch webinars, develop educational materials, provide comprehensive training programs. Additionally, we will drive initiatives to promote reasonable antibiotic use and actively engage broader community to address the challenges of antimicrobial resistance. Today's sessions started by Albert presentation on how can pharmacovigilance become active player on tackling antimicrobial misuse and resistance. And his talk served as a kickoff of our planned webinar series. So our planned webinar series aims to bring together experts to discuss key strategies and insight of combating antimicrobial resistance through pharmacovigilance and collaboration. So we are excited to continue these discussions and build on the ideas presented today. So stay tuned for our future webinars on the topic. We invite all ISoP members to join Medication Error SIG and the AMR subgroup. By joining, you can play an active role in our fighting against AMR. For those who are not members of ISoP, we encourage you to become a part of our global network dedicated for patients and medication safety. To get involved or for more information about AMR subgroup, please reach out to us on medicationerrorsig@gmail.com. We look forward to your participation and working together to make a real impact. Yeah, thank you.
Thank you so much. Thank you so much, Harry, for this presentation and invite us to this this working group. I think at the end we can just share with all of you your details so many people can join. Many people who are interested can join to this working group. So now we will pass to the question and answers. Please, all the people who are in this meeting can put your questions in the chat in the social medias that you are connecting. So we will have two speakers to answer these questions. As a moderator, I will have the opportunity to ask the first question for Dr. Figueras. I know that you pointed the problem in your presentation and many and some strategies that probably we use for the antimicrobial resistance, but I would like to know more about the role, or what role should international health organizations like World Health Organization, European Medicine Agency, FDA, etc., play in standardizing pharmacovigilance practice to address antimicrobial resistance, and how these practices can be harmonized across countries with varying healthcare capacities. I think you put in the presentation that at this moment we have been identified some methods that can be used for report at this, but these practices, what is the role of these regulatories just to standardize those practices?
Thank you, Felipe. Really, I don't know if we are in the stage of trying to standardize at regulatory agencies level, etc. In my opinion, we are first of all in the stage of just showing and just reminding reporters that in addition to suspicions on adverse events, etc., they can also report suspicions of different things, suspicions of off-label use of medicines, or suspicions of antimicrobial resistance. I mean, the first step is this one, just simply a reminder that the network is working to detect side effects, adverse reactions of medicines, but they could also be used in order to report these things that medical doctors see every day, and that patients suffer every day, so they can also report. In my opinion, this is the first stage, and of course, in the end, perhaps in the future, some terms could be redefined, some terms could be added, whatever.
So in this context of antimicrobial resistance, so what are the current challenge in reporting and analyzing all the adverse drugs reactions for antibiotic, especially in low and middle income countries? What are these actions? Because I'm from Mexico, and of course I've been living here in Spain. It's completely different both systems. So I would like to know more a little bit what is happening in those low middle income countries, so in terms of this challenge that they are, because you show this map. And especially, I agree with you that we have to focus on those countries that they don't have data, they don't have reports about it. So what are these challenges? What are the actions? What are the...
Well, there are challenges that are common everywhere, in Spain, in Dubai, and in South Africa. And these challenges of pharmacovigilance, they are funding, personnel, and reporting. Okay, the most important for a pharmacovigilance system to work are reporters and reports. If we don't have this, we don't have a, let's say, working or mature pharmacovigilance system. In many countries that are part of the WHO pharmacovigilance system, they face these problems. I mean, they have, let's say, the regulations or the legal framework to establish a pharmacovigilance program. However, they don't have enough personnel or stable personnel. They don't have constant funding, usually from the Ministry of Health. They depend in many cases from donations. In other cases, the Ministry of Health is happy to sign the general agreement to start the pharmacovigilance so they can say, yes, our country is part of this WHO network. However, in the next year, the center is completely unfunded, so the activities stop. So the problems are quite common in the end: funding, trained personnel, and reporting.
Okay, and this trained personnel, I mean, because we could have some actions at early stage for healthcare professionals. So training, I think, should be done since the school, since the degree. How can we use antibiotics for the specific conditions? Thank you so much, yes.
No, yeah, I was about to say yes.
Yes.
Healthcare professionals can be trained in the specific case of using antibiotics. In my opinion, people in general should also be trained in schools on questions such as healthy lifestyle, how to use medicines, etc., etc. And this is something that is not quite explored yet, but it's something that, in my opinion, is basic. I mean, if we want an adult population that knows about medicines, that don't listen or don't consult everything with Google, that don't start using medicines as candies, etc., etc., we must start in the school. So this is another discussion probably, but I think it's useful. And concerning healthcare professionals, of course, and the specific question of the use of antimicrobials, yes, medical schools play an important role, but also having information generated by the own country. If I have accurate information on the resistance degree of E. coli, for example, in Barcelona, when I prescribe an antibiotic for a patient that has a urinary tract infection, I will select the antibiotic that can be the best one for this patient. But if I don't have this information, of course, my natural tendency will be to say, okay, I will use the last resort, so I will cover everything. And this is the point.
Okay, thank you so much. I don't see another questions. Please, Andrea or Constanza, do you have another questions from the audience? Okay, no at this moment, please. I really encourage. This is a very important topic. If you had questions, please put it in the chat so we can discuss it. So another question, maybe I would like to have the opinion for Dr. Hager, which I can read that she is an expert in health policy. So at this moment we have antimicrobial resistance, but there are new antibiotics. So My question is more in the context, how should health policies balance the urgency of fast-tracking new antibiotic approvals with the need for robust post-marketing pharmacovigilance to monitor long-term safety and effectiveness for these new antibiotics?
Actually, one of the problem of antimicrobial resistance is having new antibiotics is not the priority for pharmaceutical companies. They focus mainly on drugs for for chronic conditions. But maybe encouraging pharmaceutical companies to invest on research for new drugs. Also from for health health policies and pharmacovigilance and antimicrobial resistance. So maybe also we need policies on encouraging healthcare professionals to do more reporting, educating them on which terms they can use and that can reflect the antimicrobial resistance, like what Dr. Albert shows the list of MedRA terms. Maybe also policies for strengthening pharmacovigilance system in the countries, strengthening the data analysis, sharing the results of data analysis with healthcare professionals to show them the impact of good reporting practice.
Okay, thank you so much. And in this area, in this line, what is the role of the primary health care what is the role in primary care for pharmacovigilance and also for antimicrobial resistance? What are the actions? Where are we taking, or what are the suggestions to do that? What are but for the question is for both, no?
But yes, then I can say something. In my opinion, it is exactly the same that for any other aspect of pharmacovigilance. I mean, when you prescribe a medicine, this ideally should be the result of thinking about the patient, reaching a diagnosis, selecting the best medicine for this specific patient, and then prescribing this medicine. But in addition to this, to take care of the follow-up of this patient and to see what happened with this patient, if he really improves his or her situation, or if the patient presents an adverse effect or a suspected adverse effect. Then, if the patient presents a suspected adverse effect, we report this adverse effect to the pharmacovigilance system. This is, let's say, the ideal path, the ideal situation. In the case of antimicrobial resistance, we see exactly the same. One patient, we prescribe one antibiotic because we think that that antibiotic is the best for the patient, and then we observe that the patient doesn't improve. So we try another antibiotic. And that not improvement is an adverse effect, or can be considered an adverse effect. This is the point. So as part of the follow-up of this patient, a medical doctor should report this adverse effect. This is how I see things. And this can be applied to hospital care and, of course, to primary health care. Over.
Thank you so much, Dr. Figueres. What is your opinion, Dr. Heather?
Yeah, I acknowledge what Dr. Albert mentioned, and they should be encouraged to report, and they should be trained on how to report and the importance of reporting.
So reporting is a key.
Yeah.
Thank you. So I have just one question for Dr. Hager. It's more about the working group that you are coordinated. It's more about real world data, because Dr. Albert tell us in his presentation about to identify some kind of cluster population. So do you think real world data, so this big database, could play a very good role for antimicrobial resistance?
Yeah, definitely, because reports that reflect prescribing practice like therapeutic failure or off-label use that reflect what's really real, what happens in the real world. So yeah, definitely it will reflect the real world practice.
Are you conducting some studies about this, which is in real world data?
Sorry?
Are you conducting some studies with real world data at
Yes.
this moment?
Yeah. One of my sub-studies is analyzing adverse drug reactions of antibiotics. Yeah.
Yes, I had another question. ISoP has now SIG about community pharmacons focused in aware about pharmacovigilance in primary care. How could we support strategies for antimicrobial resistance?
For community pharmacies, they are the first line of contact with patients. So some countries, patients just go to the community pharmacies and ask for pharmacist consultation. So if the pharmacist educate patients on reporting adverse drug reactions from antibiotics, so we will have more reports that reflect the outcome of using antibiotics. Yeah, this is what I believe.
And which pharmacovigilance activities could we implement to fight against antimicrobial resistance in a hospital? I don't know if you have experience on this, Dr. Figueres.
Well, in hospitals, usually they have a laboratory inside. Not all hospitals, of course, but many hospitals already have a laboratory, so they can send their samples to the laboratory, and they have results in at least in a few hours or a few days. Of course, this is not the case in all hospitals. If a hospital doesn't have a laboratory, then to me, it's the same. It's when you identify a case in which a patient that doesn't respond to previous treatment, then just report this. And it's the same for primary health care, and it's the same in the case of pharmacists, for example. I mean, if pharmacists ask every time that a patient comes to look for another medication, especially if it's a repetition medication, a chronic medication, or if they ask, for example, directly for an antimicrobial, etc., if they ask about how the previous treatment went, then if they do this systematically, they will be in a position to identify possible treatment failures, possible antimicrobial resistance, or even adverse events associated with medication. The point is that if you don't ask never, then you will only identify sporadic cases in which patients go to pharmacy and say, oh, I took that medicine and it was terrible. I felt terrible. But if the pharmacist, as a healthcare professional, systematically ask about the medication to patients, then they will be in a position to really identify more adverse drug reactions and be able to report these adverse drug reactions. And of course, this is also valid for medical doctors in primary health care or even in hospitals. It's important to think about the medication not only as something that is given the end of the visit as a solution to close the problem, but as a tool that sometimes is useful and other times it's not so useful. So if we are prepared mentally to identify cases in which medicines are not a good solution because the patient presented a problem, an adverse effect, then probably we will contribute to reduce underreporting.
Thank you so much for the answer, Dr. Figueres. Do you want to add something, Hager?
No.
No? Okay, I don't know if we had more questions from the audience. Andrea? Okay, we don't have more questions from the audience, and from my side, I don't have also more questions. I think this conversation has been very rich in terms of the topic. I would like to thank you, Dr. Albert Figueres and Dr. Hager, for your time and for your presentation for this topic. We encourage to continue. We encourage all the audience to continue with the activities for the ISoP. Thanks to you and all the speakers for your invaluable time and contributed to making this Patient Safety Day event possible. And I will just make a reminder, please join us tomorrow for more presentations. As I mentioned before, these Patient Safety Days will take both days, today and tomorrow, which will come from the Western Pacific region and will begin at 1 a.m. Central European time. But please visit all the ISoP channels. You will have more information about these webinars at this event, since there is more updates every day regarding those two days. So thank you, Dr. Albert Figueras. Thank you, Hager, for this, for your time. I don't know if you want to add something.
Thank you very much for the organization and for inviting me. Thank you.
Thank you.
Thank you very much.
Thank you so much. Thank you also. I would like to thank you, Andrea Gonzalez, Constanza, and Fabian, to organize the Patient Safety Day, especially for the European region. Thank you so much for all the work. And on behalf of ISoP, thank you so much for your participation today. We will continue with the activities.